Okay, so welcome everyone to the 50th lecture of Dr. Hyderi Step 1. Um, Thank you all for making it on time. And first and foremost, let me make sure that if you guys can hear my voice, can you guys hear my voice? Is my voice clear? Okay, very well. Very good. Okay, how are you all? Are you guys doing good? Can you guys tell me if you guys did the UWorld questions yesterday? Okay. Have you seen my question in the group? Yes, I shortly got the chance to view one of the questions which was posted in the morning. We were let know by one of our team members. So I shortly got to see the question. Yes. How many questions are we doing on a regular basis? I would appreciate if every one of the students can give me a solid answer. I would appreciate if every one of the students can give me a solid answer regarding the amount of questions they are doing every day, so that we know where every student stands in terms of their preparation, so that we can decide whether they are ready to take the exam in a couple of months or a bit later. Okay. Okay, let me ask a different question. Okay, let me ask a different question. The different question which I want to ask you guys today, a bit unusual from what I ask you guys every other day, is would you guys be able to tell me on an average how much time you put into your studies when you are preparing for your USMLE Step 1? Along with this, I would want to know how long, after how many days or months do you guys plan on giving the exam? Okay. Okay, for Dr. Hassan, I couldn't download the lecture 49 from Zoom. Could you please upload the lecture on Google Drive as soon as possible? Yes, we will upload the respiratory lectures on Google Drive today. So you have nothing to worry about. Okay. Okay. Question from Dr. Naud. Uh, the rest of you, or is it me, that respiratory U world has the most graph-based questions? Is this like this in the real USMLE? You, it's hard to say exactly how or what type of graphs you are referring to, but most of the graphs which we have covered will be explained in details when we associate them with the pathology. So that's that. Okay, so you have nothing to worry about in the sense that when we discussed about ventilation perfusion ratio, flow volume loops, lung volume curves, we discussed them, sure, but we will be we would be talking about them in details when we are discussing the pathology. So yeah, that's that. Okay. In general, more questions on graphs than KS. Okay. To be honest, if you have a problem with any of the graphs, you can always take a picture and upload it in the discussion group. I know we're not referring to the questions in the discussion group as of yet. We're not really getting the time, but once we get the time, we will discuss every question that's over there. That's a given. That's 100. That's 100%. Okay. Okay. Yes. What is your question? There are NBME forums where they have the answers over there. Okay. If you fail to find the answer from the NBME forum, if you upload the question, we will give you the answer. Okay. Is it possible for you guys to answer my question, please? What I wanted to know was how many hours a day are you guys putting for your preparation for USMLE Step 1, and when do you plan to give the exam? when do you plan to give the exam? It's a bit unusual, the question, regarding the sense that I always ask how many questions you guys do on a regular basis. Okay, but I would really love to know how much hours you guys are putting in your preparation from now. Okay, Dr. Hassan. Okay, Dr. Hassan, that sounds like a solid plan. Okay, that sounds very good. Dr. Khatun, 12 hours. That is extremely remarkable. Very good. Dr. Jan, okay, December 21. Very good. In 2 months, I will give 8 to 9 hours, including the lecture. Okay, very well. Very good. Anyone else? What are your plans? Anyone else? The reason why I asked you this is because how many of us are well acquainted with the term dedicated period? How many of us are well acquainted with the term dedicated period for US70 step 1? Do we all know what the term dedicated period means? Dedicated period. You know what that means? Okay. Basically, dedicated period for US70 step 1 is the period of time which is 6 to 8 weeks prior to your US70 step 1 exam. Around that time, for that 6 to 8 weeks, you need to put in at least a minimum of 8 hours. Maximum could be as maximum possible, but a minimum of 8 hours where you guys at least try to revise first aid again. Okay, so if you want to revise first aid in 8 weeks, that is in 2 months more or less, then the amount of pages that should be covered every day should be close to around 30 to 40 pages. And along with that, you should be doing a minimum of 3 blocks of UWorld questions on random every day, along with the breakdown of the questions, understanding where the problems are, why the right answers are the right answers, why the wrong answers are the wrong answers. And the next 1 or 2 hours that you have after doing all of this should be spent on either reading the pathoma or watching the videos of pathoma. Okay, so that is your dedicated period cycle. And our goal of the lectures, the fact that we are taking the first aid lectures right now, our goal is to make sure that you guys can enter your dedicated period with absolute confidence, meaning that when you start that 5 weeks or that 6 weeks or that 8 weeks of dedicated period before your USMLE step 1, you feel like you are 80% there. And the rest of the 20%, you have to brush up on revision, recapitulation, doing questions, getting ahead of the timings, proper rest, okay? And all of those stuff. NBMEs every other week and all of those stuff. And we would be there to help you along the way to how to plan your dedicated period. We would have a lesson schedule for you, so you have nothing to worry about. But that is the goal of our lecture. Our goal of the lecture is to make sure that you enter the dedicated period with confidence. That's that. Okay, so with that being cleared, before we begin respiratory pathology today, can we do a small revision of yesterday's topic before everyone comes? Can we do a small revision of the topic from yesterday before we move forward? Everyone, are you guys ready to do a small revision and recapitulation of the previous topic before we move forward? Okay. Okay, very well. Okay, so let's start with respiratory physiology. In respiratory physiology, what is the name of the lung volume that moves with each quiet inspiration? And it's typically around 500 milliliters. Very good. What is the volume of air that can be breathed in after a normal inspiration? What is the volume of air that can be breathed out after a normal expiration? Okay. What is the maximum volume of gas that can be expired after a maximum inspiration? Okay. Next one is in a normal patient, is the physiological dead space equal to the anatomical dead space? Okay. What is the term used for the tendency of the lungs to collapse and the outward pull of the chest wall? Okay. What is the term used for the ability of the lungs to stretch as much as possible? Okay. What is the term used for the lungs to use more pressure to inflate than to exhale? Which hysteresis? Very good. Okay. What are the changes in the lungs? What are the what are the factors that are increased? What are the factors that are increased in the lungs in elderly people? Residual volume, compliance, VQ mismatch, and AA gradient. Very good. What are the factors that are decreased in an elderly people in an elderly person? FEV1, FVC, chest wall compliance, respiratory muscle strength. Very good. Okay. What is the cause of methemoglobinemia? What is the cause of methemoglobinemia? Okay, very good. Okay, how do you treat a patient with methemoglobinemia? Okay, what are the causes of right shift of the oxygen hemoglobin dissociation curve? Okay, okay. What are the causes of the left shift of the oxygen hemoglobin dissociation curve? Okay, very good. Okay. How will you treat a patient with cyanide poisoning? How will you treat a patient with cyanide poisoning? Okay. How will you treat a patient with carbon monoxide poisoning? Okay. Next one is okay. If pulmonary vascular resistance is 8 into viscosity into length divided by pi r to the power 4, if everything is constant and the radius is increased by a factor of 2, how much has the resistance decreased? Okay. What are the causes of hypoxemia with normal AA gradient? Normal AA gradient, high altitude and hypoventilation. Very good. Okay. What are the causes of increased AA gradient hypoxemia? Okay. What are the forms by which carbon dioxide is traveled or transported in the blood? Bicarbonate, carbaminohemoglobin, and and dissolved carbon dioxide. Very good. And dissolved carbon dioxide. Okay. And okay. The next one is okay. Um, what are the changes in the lungs or changes with acute response to high altitude? With acute response to high altitude, do you have altitude sickness and respiratory alkalosis? Okay. What are the changes in the lungs with chronic increase in high altitude? Do you have, what do you have with chronic increase in erythropoietin? Very good. Okay. Next one. Next one is with response to exercise, does the oxygen hemoglobin dissociation curve, does it move to the left or to the right? To the right. It does not move to the left. Exercising is always right. So oxygen hemoglobin dissociation curve moves to the right. Okay. Okay. So with that being said, we can begin our lecture for today. That is the respiratory pathology, rhinosinusitis. That's what we'll begin with. Okay. Are we all ready? Okay. Very well. Very good. Let's begin. Okay. So let's begin with respiratory pathology. Okay. So what we're going to do is we're going to read, and then after, if there's anything needed to discuss, we're going to discuss this on a blank page. That's what we're going to do. Okay. So let's start. Let's begin. First of all, respiratory pathology. The first thing that we want to talk about is rhinosinusitis. Rhinosinusitis. Basically, what rhinosinusitis is that this is basically an obstruction of the sinus drainage into the nasal cavity. So if we have an obstruction of a sinus drainage uh, distal to the obstruction, what we have is we have a blockage. So if anything stays for a long time in the body, that is stasis, this is a high yield ground for growth of bacteria, and this can have infections and inflammations. So what the patients have is they have inflammation and pain over the affected area. It typically affects the maxillary sinus, which drains against gravity due to the ostia located superomedially. If you can see over here that the ostia is located superomedially. Okay, so this is high yield for your Usmle step 1. That is, which one is more common? The common one is maxillary sinus. And why is this more common? Because the ostia is located superomedially against gravity. This is your answer. Okay, please underline this. That is, if you can see over here, that this is the drainage, right? This is located against the gravity. So there's a more higher chance of this to be stasis or to stay over here. And that's why rhinosinusitis is more common in the maxillary sinus. Okay. Having said that, there are some things that we want to talk about. That is the superior meatus and the middle meatus and the inferior meatus. What do we mean by the word meatus? Meatus means that the potential openings through which the sinus can drain. Okay, the potential openings in the nasal cavity where the sinus can drain. So what we're going to do is we're going to talk about the three meatus, that is superior, middle, and inferior. Okay, so superior meatus. Okay, so superior meatus. I'm doing this on a different page so that you guys can find it easy. Okay, superior meatus is sphenoid and posterior ethmoid. Okay, middle meatus is frontal, maxillary, and anterior ethmoid. and inferior meatus, inferior meatus will drain the nasolacrimal duct. Nasolacrimal duct. Okay. So please write this down over here so that you guys can have a quick revision when you guys are doing the first aid. Just write it down very in okay as little as possible, as small as possible. That's a superior meatus, inferior meatus, middle meatus, and you guys will be asked questions about this in your USMLE step one. Okay, so superior meatus is SPE, meaning sphenoid posterior ethmoid. Middle meatus is FMAE, meaning frontal maxillary anterior ethmoid. Inferior meatus is nasolacrimal duct. That's that. Okay, so that is high yield. What are the most common causes of the most common cause is viral upper respiratory tract infection. This may lead to superimposed bacterial infection. Most commonly, these are the three most common organisms for rhinosinusitis. That is Haemophilus influenza, Streptococcus pneumoniae, and Moraxilla catarrhalis. But the thing is, you don't have to remember this right away like this, because when they have questions, they will have microbiological associations um, of these organisms, and they will try to explain how each of them are. For example, for influenza or for Streptococcus pneumoniae, they will mention that it's a gram-positive organism, right? And that's that. So they will try to make sure that you can identify the organisms based on the properties of the microbiology, right? So you don't have to remember this. Paranasal sinus infections, meaning the nasal that is peripheral to the sinus infection, they may extend to the orbits, paranasal infection, cavernous sinus and brain, causing complications. Example, orbital cellulitis, cavernous sinus syndrome, and meningitis. Not high yield. Okay, this is not high yield. Okay. Next one. Next one is epistaxis. Before we move on to epistaxis, what are the drainage of superior meatus? Can I get some fast answers, please? Superior meatus. Can I get some fast answers? What are the drainages of superior meatus? Sphenoid, posterior ethmoid. What are the drainage of the inferior meatus? Exactly. What are the drainage of the middle meatus? Of the middle meatus? Frontal, maxillary, anterior. Very good. Okay. Okay, very good. First of them, once again, superior meatus, sphenoid, posterior ethmoid, then middle meatus, frontal maxillary, anterior ethmoid, inferior meatus is nasolacrimal duct. Okay, that's that. Next one is epistaxis. Epistaxis is basically the term used for nose bleeding. The most common location is at the anterior segment of the nostril, that where there's a plexus called the Keisel back plexus. The plexus is known as Keisel back plexus. Over there, what you can get is you can get life-threatening hemorrhage, which can occur in posterior segment, and the artery that is responsible is high yield for the step one. That is, they will ask you the source. That the source is this is the branch of the maxillary artery, which is the sphenopalatine artery, which is the branch of the maxillary artery. If I talk about the maxillary artery, can you guys tell me very quickly from which aortic arch does the maxillary artery come from? Maxillary artery. Aortic arch. Maxillary artery. Okay. What is the artery that is coming from the second aortic arch? Isn't it stapedial and hiatal artery, right? Okay, very good. So sphenopalatine artery, a branch of maxillary artery. The common cause includes foreign body trauma, allergic rhinitis, and nasal angiofibroma. So the thing is that there are nasal angiofibroma. This can come regarding an association with the fact that you can get an adolescent male, a male adolescent with excessive nasal bleeding, and nasal angiofibroma is basically a type of tumor that can occur in the nose, for which the patients can get life-threatening hemorrhage. Don't forget that the plexus is Kieselbach plexus, and the artery is phenophalatine artery. Okay, so what are the arteries that are there in the chiasal back plexus. The arteries that are there in the chiasal back plexus are, what are the arteries? First of all, you have labial artery, then you have ethmoidal artery, you have ethmoidal artery, then you have greater palatine artery, then you have sphenopalatine artery. Sphenopalatine artery. So these are the four arteries of the chiasal back plexus. So the mnemonic is legs. Labial, ethmoidal, greater palatine, sphenopalatine. Okay. So these are the four arteries of the chiasal back plexus. Okay. The questions will come in the sense that which of the following arteries are not a branch of chiasal back plexus, or which of the following arteries are a branch of chiasal back plexus. So if you have these in mind, you can answer those questions correctly every time. Okay. So with that being said, let's move forward. The next thing that we want to discuss is head and neck cancer. Head neck cancer is mostly it's a squamous cell carcinoma. The risk factors are basically tobacco, alcohol, and high risk HPV, that is HPV 16, and Epstein-Barr virus, which can cause nasopharyngeal carcinoma. Okay. Another thing about risk factors that is with tobacco, alcohol, and HPV is there's a term that is known as field cancerization. Field cancerization basically means that when the area of the head and neck, it is so highly vascularized, and it's very highly supplied by lymphs. And so what happens is when a certain tissue of the head and neck portion, due to its high vascularity, when it gets exposed to a carcinogen, that carcinogen can travel throughout the whole mucosa of the head and neck due to the high vascularity, which can result in carcinogen, which can damage a wide mucosal area. So what happens is multiple tumors can develop independently after exposure, meaning that if it's a long time smoker, there's a possibility that the smoker can have a tumor in the mouth, that's in the tongue, or in the buccal mucosa, or in the esophagus, or in the vocal cords, or in the trachea. Okay, so throughout that whole area. So this is known as field cancerization. This basically means that the carcinogenic exposure has been exposed throughout the whole mucosal area of the head neck portion. So that's what it means. That is field cancerization. Okay. That's that. Okay, next one. Next one is DVT, deep vein thrombosis. Basically, what is deep vein thrombosis? This is basically, uh, okay, first of all, before I move forward, head and neck carcinoma over here. The only thing that you have to know is the most common cancer is squamous cell carcinoma, and the risk factors are tobacco, alcohol, and HPV 16. That's the only piece of information that's important over here. Field cancerization is not important. Okay, field cancerization is not important. Next one. Next one is deep vein thrombosis. Deep vein thrombosis is basically it's a blood clot within a deep vein, which can cause swelling, redness, warmth, and pain. Okay, it's predisposed by the Vercos triad. Okay, let's talk about this one over here. This is actually very high yield. Deep vein thrombosis. What happens is when you have a patient who has been who has a hypercoagulable blood, or a patient who has long-term endothelial damage, or a patient who has not been moving for a long period of time. Okay, so what did I tell you? I told you about, okay, the causes of DVT. Causes. There are three basic causes. Okay, there are three basic causes. First of all, if there is, uh, first of all, if there is stasis. Stasis basically means no movement. For example, during post-operation or long flight, okay? So, or sitting in a chair for a long period of time, not moving, then quadriplegic patients, so stasis, okay? Stasis, that's number one. Number two is hypercoagulability, meaning that a person who has a hypercoagulable blood, hypercoagulability, okay? So hypercoagulability can occur such as in OCPUs or factor 5 mutation, which is the most common cause of hypercoagulability. And then the next one is Then the next one is endothelial damage. If we have a patient with endothelial damage, if we have a patient with endothelial damage, these patients, they are exposed to the collagens that can trigger the coagulation cascade. For example, if there is endothelial damage, we can have the activity of the intrinsic pathway, and then you can get that and then you can get the formation of the coagulations, right? And then there will be formation of a thrombus. So these are the three things that leads to a formation of a thrombus: stasis, hypercoagulability, and endothelial damage. These three things altogether, this is known as Varco's triad. These three things altogether, these are known as Varco's triad. Okay. And what are the clinical features of DVT? The clinical features of deep vein thrombosis are basically the sign symptoms of more or less inflammation, right? So with inflammation, the sign symptoms. What are the sign symptoms? That is the 5 signs of inflammation. 5 signs of inflammation. That is tumor, rubor, dollar, calor, loss of function. Okay, so tumor, rubor, dollar, calor, and loss of function. By that we mean tumor means swelling, dollar means pain, rubor means induration, calor means calor means increase in heat, and means warmth, right? And loss of function means the patient cannot move. So the sign and symptoms are basically that. Okay, what do we do when we want to test clinically to see if the patients have a higher chance of developing DVT? What do? We do this test, which is known as D-dimer test. D-dimer test. Okay. Okay. Do we have a lot of doctors over here who were frontline workers or frontline helpers in the coronavirus pandemic? Do we have any doctors over here who has been frontline workers in the coronavirus pandemic? Anyone? Anyone? Can you guys hear my voice? Okay, Dr. Hassan, thank you so much and congratulations. Okay. Anyone over here except Dr. Hassan? Okay. So a big round of applause for Dr. Hassan. Thank you so much for doing what you are doing. Okay. The reason why I'm asking you the if you guys are well aware of coronavirus, in the sense that in coronavirus, there has been a possibility of seeing hypercoagulability. And one of the tests that we do is D-dimer tests. One of the tests that we do is D-dimer test. Okay, I'm not sure if you guys knew about this. Just in case you guys expect or receive these type of questions, just keep in mind that D-dimer test is a test that we do to rule out hypercoagulability. And we also do this in coronavirus to see if there is a hypercoagulability, because a lot of patients, they die from hypercoagulability, such as pulmonary embolism or any other causes. So D-dimer test, D-dimer is used to detect the hypercoagulability. And we can do D-dimer to see if there is any patient who is at high risk of developing DVT. And the imaging, if we can also do an acute imaging. In acute imaging, what we would do is compression ultrasound with Doppler. Compression ultrasound with Doppler study. Okay, with Doppler. Compression ultrasound with Doppler. And what do we do to treat the patient? These are the diagnostic tests. These are the diagnostic. What do we do to treat a patient? To treat a patient, what we do is, what we would give them is, we would give them two things. One is for acute management, another one is for long-term management. Okay, for acute management, that is for right now, that is immediate action, what we would do is we would give them low molecular weight heparin. We would give them low molecular weight heparin or unfractionated heparin, okay, for example, enoxaparin or dalteparin, right? And for chronic, what we would do is we would give them oral anticoagulants. For example, rivaroxaban, rivaroxaban, or apixaban, apixaban. Okay. Okay. Having said that, let's read the text now. Let's see if we have covered everything. First of all, deep vein thrombosis is blood clot with a deep vein. Thus, we talked about the Verco's triad, that is stasis, hypercoagulability, endothelial damage. Hypercoagulability is a defect in coagulation cascade, such as factor V mutation in OCPUs. Endothelial damage, where the exposed collagen will trigger the clotting cascade. We talked about this. Pulmonary emboli can arise from proximal deep veins of lower extremity. Okay, they can arise from the over here. So that's why DVTs are so dangerous. Okay. Okay. Next one is D-dimer lab test. We will do D-dimer to see if it's clinically significant to rule out DVT to moderate to high risk patients. And then if we want to confirm it, we can do compression ultrasound with Doppler study. And the treatment is basically we can give unfractionated heparin or low molecular weight heparin for acute management and oral anticoagulants such as rivaroxaban and apixaban for treatment and long-term management. This is high yield. Okay, there's high yield. Okay, another thing that I want to talk to you guys about is superficial thrombophlebitis. Okay, you will be asked multiple times. You will be asked multiple times what is superficial thrombophlebitis and what is DVT. So you have to know the differentiating symptoms. Superficial thrombophlebitis, this is basically an inflammatory condition of the veins where there's a blood clot just below the surface of the skin. Okay, this usually occurs in the legs and it can occasionally occur in the arms and neck. Okay, the reason why I'm discussing about this right now is you will be asked a lot of questions based on your knowledge of superficial thrombophlebitis and DVT. So you have to know how to differentiate these two conditions. Okay, the symptoms are usually the same as DVT, that is swelling, pain, and redness. Okay, and basically this occurs because there is a blood clot below the surface of the skin. Okay, just below the surface of the skin, that is in the superficial veins, and deep vein thrombosis are basically in the deeper veins. They're more common in common in females when compared to males. Okay, the treatment is basically we will give anti-inflammatory medications and cold or warm compresses. Okay, let's look at the picture. So superficial thrombophlebitis. This is how a picture of superficial thrombophlebitis would look like. Okay, this is how okay, superficial thrombophlebitis. Okay, so that's that. If there's a blood clot just beneath the surface of the skin, it will be red, swollen, and pain, and that's that. Okay, along with this, there's also another thing which I want you guys to see. Okay, this is varicose vein. I mean, look at how in varicose vein you have varicosity of the veins, but the overlying skin is not swollen, pain or painful or indurated. So that is varicose vein. So varicose vein, superficial thrombophlebitis, and deep vein thrombosis. These three things you have to have very clear-cut knowledge. Okay, one is clot in the deeper veins. Another one is clot in the superficial veins. Both of them can have swelling, redness, and pain, but deep vein thrombosis are more dangerous because they can go and reach the systemic circulations and can cause stroke via saddle embolus. They can reach the pulmonary circulation from the right heart and cause pulmonary embolism. Okay, and in superficial thrombophlebitis, the chance of embolus formation is low, although the pain and swelling and the signs and symptoms are much more exaggerated in superficial thrombophlebitis. In varicose veins, you just have varicosity of the veins without any sign symptoms. That's that. Next one. Is there any risk of pulmonary embolism in superficial thrombophlebitis? Not really. There is not a lot of risk of pulmonary embolism in superficial thrombophlebitis until and unless there is an underlying deeper vein thrombosis. Okay, so that's that. Okay. Having said that, let's move on to the next topic. Okay, let's move on to pulmonary emboli. Okay, let's move on to pulmonary emboli. Have you guys understood the first page of the respiratory pathology? Yes, there is risk of skin infection. Okay. Let's discuss pulmonary embolism. For pulmonary embolism, before we discuss pulmonary embolism, you will receive at least 5 questions based on this CT scan. Based on this CT scan. Okay, and we will talk about this, but just try to understand the importance of this CT scan alone over here, which shows an emboli. Okay, in pulmonary embolism, we talked about ventilation perfusion ratio yesterday. We said that how VQ has to be 1 for adequate gaseous exchange. If perfusion is low, that is in pulmonary embolism, okay, what happens is you have low perfusion, right? So ventilation is okay, meaning that air can come in, but the lungs are not adequately perfused because there's an embolus blocking the flow of blood. So perfusion. So what happens is if we do a VQ study, then ventilation is increased, perfusion is decreased. Okay, so what we get is we get a VQ of more than 1, which is not adequate for gaseous exchange to occur. So there's a VQ mismatch over here. Okay. Along with this, we will get hypoxemia and respiratory alkalosis. Can anyone tell me why we will get respiratory alkalosis? Why do we get respiratory alkalosis? Right. So there is hyperventilation because the patients will be gasping for air, and hypoxemia will trigger the ventilation, trigger the breathing centers, and the patients will hyperventilate. So respiratory alkalosis. What this will do is this will cause us a sudden onset of dyspnea, chest pain, tachypnea, and tachycardia. This is very, very important. What are the sign symptoms? Sign symptoms are the patients will suddenly be out of breath. All of a sudden, out of nowhere, in a patient with no previous history of asthma or any other sign symptoms. Have you guys ever had a foreign body stuck in your windpipe before, during, for example, during eating? Do we have anyone over here who has had that experience, that horrible experience of a foreign body being stuck, or food being stuck in your windpipe? Okay. Do you know how that feels? That feeling of impending death and that scariness when you can't breathe, right? And you just coughing it out. Does everyone understand what I'm talking about? Right? That is the type of feeling. That is the type of feeling these patients will get. That is the type of feeling these patients will get. That is, all of a sudden there will be dyspnea, or they will have a very pleuritic chest pain. What do you mean by pleuritic chest pain? This means that there will be chest pain with each and every breath. With each and every breath, when the lung expands, there will be pain. When the lung deflates, there will be pain. So pleuritic chest pain. Along with this, there will be increase in heart rate and respiratory rate. If there's a large embolus or a saddle embolus, for example, this is a saddle embolus. Okay, what do we mean by a saddle embolus? Basically, this means that if there's an ASD, a very small ASD in a patient over here, okay, okay, uh, no, my apologies. That is paradoxical embolus. My apologies. I'm so sorry. A saddle embolus is that. Let's talk about paradoxical embolus. One second. Paradoxical embolus is basically if you have a patient who has an ASD and then the embolus comes and then it crosses from here to here and then it goes all the way to the brain and it causes a stroke. That's called a paradoxical embolus. Saddle embolus is basically the embolus going and it's obstructing the bronchus like a saddle. By that, we mean the saddle is a piece of sitting mechanism that we use to sit on the back of horses, for example, like this. Okay. So what happens is that you have the bronchus. Okay. You have the bronchus, and then you have the arteries which are supplying the bronchus, right? They go and they block the big arteries that are supplying the bronchus. And what happens is from over there they cause that feeling of sudden onset of dyspnea, chest pain, tachypnea, and tachycardia. So that's what your saddle embolus is. Okay, so that is basically, in a very small, or I mean in very basic terms, a saddle embolus is basically the term used for a large embolus. Okay, so large emboli or saddle emboli, that is this one over here. This may cause sudden death due to electromechanical dissociation or pulseless electrical activity. Okay, so what happens is that when it goes over there, when it goes and it obstructs the artery supply, there is there is a sudden there is a sudden cardiac there is a sudden cardiac death, because what happens is when they realize that there is a blockage of the blood that is going to the lungs, then they try to increase the blood supply. The heart tries to increase the blood supply, and when they feel that they cannot push beyond the emboli, the heart, they kind of stop. So they can have sudden cardiac death, and that is due to the electromechanical dissociation. This is not very high yield, to be honest. Okay, so that's that. Okay, if we do a CT angiogram, keep in mind how that in pulmonary embolism, the CT angiogram is the only thing that can be used to diagnose and confirm the pulmonary embolism. Okay, so if you do an X-ray in a patient with pulmonary emboli, if you do an X-ray in a patient with pulmonary emboli, do you think that the X-ray will be a normal X-ray, or there will be a change in an X-ray? Will there be a change in an X-ray? Okay, X-ray will be completely normal. Okay, X-ray will be completely normal. So you cannot diagnose a patient on X-ray. X-ray will be completely normal. So what you have to do is you have to do a CT angiography. When you do a CT angiogram, something like this, then you can see that there is a filling defect. Okay, as you can see over here, that there is a filling defect. The CT angiogram is the test of choice for pulmonary embolism, where we will look for the filling defect. As you can see over here, that this is the embolus. Okay, this is the embolus over here, and this is causing the filling defect. Let me show you another CT scan picture of pulmonary embolism. This one. Okay, look at this one. This is very, this is also very high yield. Okay, over here, as you can see, that there is a filling defect. Okay, this thing that looks like a inverted vertebra over here. Okay, again, the same thing over here. Okay, this is known as the filling defect that you can see in the CT scan. Okay, so that's that. Okay, and another thing is, if we do an ECG of these patients, although it's not very high yield, if we do an ECG, what we can see is we see these type S1 Q3 T3 pattern. Okay, if you do an ECG of a patient of pulmonary embolism, what you find is this this type of these type of ECGs. Okay, 1 second. Okay, what you find is you find S1 Q3 T3 pattern that is in the first lead. That is in the first lead. What you see is that the S QRS S is a bit downer than it was supposed to be. Okay, so the PQRS S1, the S1 basically means that the S in the first leads. Look at all the S's in the first lead, how they are uh, extended a bit downwards more than they should be over here. Okay, and then and in the third lead, that is over here, you see the Q and the T. Okay, how look at how everything that in the T, what you can see is that there is an inversion of the T waves. The T waves are more or less inverted in the third lead, and the Q in the third lead, they're also a little bit slightly in there. There's a slight inversion over here. Okay, to be honest, you will not be tested on this a lot when you give the actual exam. That is, they will not give you S1 Q3 T3 ECGs, but for example they do. The only thing that will help you is if you treat T wave inversion in 3 instead of 1. Instead of in the one, the T will be okay. But if you see T3 inversions in the third lead, then try to look for S. If the S looks more downward than it does, then high possibility that these ECGs are uh, your uh, your ECGs of pulmonary embolism. So S1, Q3, T3 ECGs. Okay, so that's that. If you guys want, you guys can take a picture of this, or this will be in the lecture in the recording. So you have nothing to be worried about. Okay, so that's that. Okay, they have S1, Q3, T3, and then once again, if you do histology, then you can see lines of Zan. We talked about this. Lines of Zan are interdigitating areas of pink and red. Pink and red. Pink are basically platelets and fibrin. Reds are the RBCs, and they're found in thrombi before death. Okay, and we use lines of Zan to distinguish pre or post-mortem thrombus. We talked about this before. Do you guys remember our discussion of lines of Zan from our previous topic? Yes or no? Okay. Before we move forward, can we do a quick recapitulation of pulmonary embolism? First of all, pulmonary embolism. What are the three lung function tests which will be different? First of all, what happens to VQ? Will there be a VQ mismatch? Yes or no? Okay. What happens to the oxygen level? Will it decrease? Okay. Will there be respiratory alkalosis or acidosis? Okay. Okay. What would happen? What are the clinical features of pulmonary embolism? What are the clinical features of pulmonary embolism? Okay. Then the next one is what are the types of ECG changes you can see in pulmonary embolism? ECG changes, fast answers, please. S1, Q3, T3. Okay. How do you, okay. Next one is how do you diagnose pulmonary embolism? Okay. How would you know if an embolism or an emboli is pre-mortem or post-mortem? Okay. What are the types of pulmonary embolism? The types of pulmonary embolism are basically there's fat, air, thrombus, bacteria, amniotic fluid, and tumor. So fat bed. Okay. And the questions that you will receive from fat emboli, okay, are the patients will come with a history of long bone fracture, for example, a fracture of the femur or the fracture of a tibia. This is very high yield. Okay, please underline this, that every patient with pulmonary embolism or fat emboli will come with a history of long bone fracture. So that's that. And the patients will have a classical triad of hypoxemia, neurological abnormality, and petechial rash. Neurological abnormality and petechial rash, the patients can have hypoxemia and neurological abnormality because the emboli can go and then they can cause obstructive sign symptoms in the vascularity of the brain. So that's why they can have neurological abnormalities. So and fat emboli, the patients will have a history of long bone fracture. That's that. In air emboli, what would happen is the patients will have a history of diving. So what happens is when they dive really low, there are formations of nitrogen bubbles. Okay, so these nitrogen bubbles, they enter into the blood vessels, and then they travel all the way up. And when these bubbles are there, they're just as bad as an embolus or a thrombus, because they prevent the flow of blood forwards. So in air emboli, they can have um, air emboli, there will be a history of diving or deep sea divers. And you can treat this very easily, that this can be treated with hyperbaric oxygen. Okay, so the hyperbaric oxygen, the high flow of oxygen, will push the bubble away, and that can cause release of the obstruction. Next one is amniotic fluid embolus. Amniotic fluid embolus, they typically occur during labor or postpartum, okay, and or they can occur during trauma. Another thing is, we talked about this, how the amniotic fluid embolus, how there are certain things, for example, DIC, this is more common in patients with abortion, or during or labor, or any other pregnancy complication, for example, abruption of placenta, where you have the release of tissue factors, and all these tissue factors can lead to the coagulation pathways being activated, and this can lead to the formation of disseminated intravascular coagulation. So when you have overall disseminated intravascular coagulation due to the release of tissue factors, this can lead to the formations of small thrombus, which can travel all the way up to the lungs and causing pulmonary embolism. And this is the most common cause of pulmonary embolism. The most common cause of pulmonary embolism, if the patients do not have a history of long bone fracture, the most common patients you will find are pregnant patients with a sudden history of breathlessness. Okay, a patient during labor, or postpartum patients with a sudden history of onset of breathlessness, chest pain, tachycardia, and tachypnea. And the first thing you should think about in USMLE and in your life as a physician is pulmonary embolism. Pulmonary embolism. Okay, are we clear about pulmonary embolism? Prognosis of pulmonary embolism. Prognosis of pulmonary embolism is 100%. Um, the longevity is very high, depending on the fact that you release the obstruction and the embolus. If you get rid of it, then the chances are very high that you will survive the embolus. Okay, but you have to get rid of the embolus right away. Okay, the last sentence which I said was, there are two types of patients which will come to you with pulmonary embolism. One type of patient will have a history of long bone fracture. Another type of patient will come to you with a history of labor, postpartum, or the patient is in postpartum, or the patient is a pregnant patient with a sudden onset of dyspnea, chest pain, tachycardia, and tachypnea. Are we clear? These are the two types of patients you will get according to the presentations in USMLE, your or in your actual life as a physician. Okay, so that's that. Okay, can we move forward? Can we move forward? Okay, very well. Next one is mediastinal pathology. Okay, mediastinal pathology. When we talk about mediastinal pathology, are we all acquainted with the fact that what is a mediastinum? Do we know what a mediastinum is? What is a mediastinum? What is mediastinum? Anyone? Okay. Okay. So the cavity. Okay. So this is the cavity of the thorax, basically, the cavity of the thorax between the diaphragm and the suprapleural membrane. Okay, this between the diaphragm and the suprapleural membrane. How many types of mediastinum do we have? How many mediastinum do we have? Okay, let's talk about the mediastinal pathologies. Okay, the mediastinal pathology is that the normal mediastinum, this means the cavity between the diaphragm and the suprapleural membrane. This mediastinum, they contain the heart, thymus, lymph nodes, esophagus, and the aorta. Okay, and some pathologies that can occur in any compartment, but the pathologies that are associated with each and every one is, first of all, we have the anterior mediastinum. The anterior mediastinum is all T's, all T's. T's for 4T, 4T. T for thyroid, thyroid, then thyroid. For example, we can have goiter or thyroid carcinoma. That's that. Then T for thymus, or for example, any type of neoplasm of the thymus, then we can get a teratoma, or a lymphoma. Okay, although lymphoma is not a T. So what first aid does is they talk about lymphoma by saying that it's terrible lymphoma. So thyroid thymus teratoma and terrible lymphoma. That is the anterior mediastinum. If we talk about the middle mediastinum, the middle mediastinum, they contain esophageal carcinoma, then hiatal hernia. Hiatal hernia basically means the part of the stomach which has herniated up through the esophageal aperture of the diaphragm. So hiatal hernia. Then bronchogenic cysts. We talked about bronchogenic cysts before, and that can be over there. And posterior mediastinum is very easy to understand because posterior mediastinum can have only two things. First is a neurofibroma and multiple myeloma. So once again, the anterior ones are four T's, that is thyroid, thymus, teratoma, terrible lymphoma. The middle ones are esophageal carcinoma, hiatal hernia, bronchogenic cysts, or any other metastasis can go and they can affect the middle mediastinum. Posterior mediastinum is neurofibroma and multiple myeloma. Out of all of this, the anterior one is very high yield. And anterior one is very high yield. That is anterior mediastinum. You have the four T's. Okay, so that's that. So anterior mediastinum with the four T's. Okay, are we clear about this? Are we clear about mediastinal pathology? Are we clear about mediastinal pathology? Okay, very well. Next thing that we want to talk about is mediastinitis. Mediastinitis is basically inflammation of the mediastinal tissue. They're commonly due to post-operative complications of cardiothoracic procedures. For example, in esophageal perforations or contiguous spread of odontot of odontogenic and retropharyngeal infections. Basically, if you have any types of collections after an esophageal operation or any other procedure, then they can cause inflammation of the tissue, and this is called mediastinitis. There could be acute and chronic. Obviously, in chronic, there will be fibrosis. So you have fibrosing mediastinitis, and this is due to proliferation of connective tissues in the mediastinum. And the most common cause is histoplasma capsulatum. And in acute one, you have the acute infections. So that's that. And in the clinical features are basically fever, tachycardia, leukocytosis, chest pain, and sternal wound drainage. Okay, these are not high yield. Okay, you will not receive a lot of questions from over here, so there's not much that you have to learn about this. Okay, so just try to remember anterior mediastinum, and you guys should be okay. Okay, so nothing to be very worried about from mediastinal pathology. Not very commonly asked, not very common in the clinical setting either. Next one is pneumomediastinum. Pneumomediastinum is basically this is presence of gas in the mediastinum. As you can see over here with the black arrow, that we have the presence of the gas in the mediastinum, which can be either spontaneous. Well, spontaneous pneumomediastinum, meaning that if there is a rupture of a pulmonary bleb. For example, if you have a pulmonary bleb, meaning that if we have a formation of a bleb-like structure in the pulmonary, in the lung region, for example, in case of a tall young male, okay, if there's a tall young male, and for example, in case of let's say Klinefelter syndrome, okay, in case of Klinefelter syndrome, if we have pulmonary bleb in those males, and if there is any trauma or if there is any type of contact sports which the patient can go through, they can have the rupture of the pulmonary bleb, and through that pulmonary bleb, air can come in, and they can get accumulated in the mediastinum, causing pneumomediastinum. That is what I'm trying to say. Another one is iatrogenic, traumatic, or Boerhaave syndrome. Well, what is Boerhaave syndrome? Did we talk about Boerhaave syndrome before? Yes or no? Boerhaave syndrome. Yes, we talked about this in gastrointestinal system. Boerhaave. Who remembers Boerhaave? Esophageal rupture. Very good. Esophageal rupture. Okay. 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 Does the lung collapse? The lung collapses in pneumothorax. The lung collapses in pneumothorax, not more or less in pneumomediastinum. Okay. So no, over here the lung does not collapse. Okay. And so what happens is over here, the ruptured alveoli allow tracking of air into the mediastinum via the peribronchial or perivascular sheets, meaning that there are small spaces over here through which the air can go out and they can accumulate, but this air is not high enough to cause the collapse of the lungs. So it's not, so they will not put a lot of pressure, but they will cause chest pain, dyspnea, and subcutaneous emphysema. This is known as Hammond sign, positive Hammond sign. This is also positive in Boerhaave syndrome. We talked about this before. That is, Hammond sign is if you try to auscultate the esophageal area or this area, what you will see is you will see that there is crepitations. And if you try to auscultate the heart, we do not expect to find crepitations on heart auscultations, but you will find crepitus on heart auscultations. And if you find crepitus on heart auscultation, this is known as Hammond sign. And this Hammond sign is positive in pneumomediastinum and Boerhaave syndrome. These are the two causes of Hammond signs, that is pneumomediastinum and Boerhaave syndrome. So you have to think about two things. Either there is a pulmonary bleb rupture or there is an esophageal rupture. Two things for Hammond sign. Okay, are we clear about this? Okay, I really can't see the air in the lungs. Okay, the air in the lungs, the air is not in the lungs. The air is supposed to be around the mediastinum. If you can see this portion of air over here. Okay, this small portion of airy region over there. Okay, what is high yield here? It's not high yield. It is not very high yield. If it was high yield, I would have mentioned it with the start. The highest yield it could be that you can receive some questions from Boerhaave syndromes and pneumomediastinum by them that they can mention that there has been a positive Hammond sign. If there is a positive Hammond sign, just think about two things. That is pneumomediastinum and uh, Boerhaave syndrome. Okay, that is the only thing you need to know from over here. None of these things are very high yield, except pulmonary embolus is very high yield. That's that. Mediastinal pathology is not high yield. Okay, are we clear? Okay. How are we doing so far? Are we understanding the respiratory pathology? Okay, we're taking things very slow. Some of the things which I do not put a lot of emphasis on, it's because it's not very high yield, so you do not have to understand. Okay, so that's that. Okay, the next one that we want to talk about, okay, then the next thing that I want to talk to you guys about is flow volume curves or flow volume loops. This is very high yield. Do you guys remember that we talked about this in our UWorld lectures that we mentioned a lot of them? We mentioned different types of these curves. Yes or no? Okay. Now is the time we discuss about this. Okay. First of all, let's take our blank page and let's discuss what's happening over here. Okay. Okay. So first, what we would do is we would draw a normal one, and then we would see what the difference is. Okay. Okay. So this is the normal flow volume loop. What you have over here is at first. Okay. Okay. So flow volume loop basically means that this is the flow of air. Okay, flow of air is basically in liters per second. Flow of air is the amount of airs in liter, or the amount of oxygen in liter that is flowing inside and outside of your lungs per second. Okay, and this is the liter. Okay, this is the liter. Meaning that the amount, okay, the amount or the amount of air that is in liters over here. Okay, now what we have is we usually have the reading from this way. Okay, but since there is inspiration and expiration, the readings are usually from the opposite way over here. So it will start from 0 2, then we can have 4, then 6, and 8. Okay. Okay, because what happens is when you try to breathe in, okay, when you breathe in the air, and if we drew this from this way, then we could not complete the diagram, because what happens is, if we drew it from 0 to 6, or from 0 to 8 through this way, then the diagram would be completely inverted, and it would cause a lot of confusion. So flow volume curve, the only anomaly with flow volume curves is that the labelings are from the opposite side, so that it's easier to draw the diagram. Okay, so that's what we mean. And if we have the liters per second over here, that is, if you inspire, meaning this is the positive air that is coming into your lungs. So that is, so this is 4, 8, and if you expire, that is the negative air that is in your lungs. Okay, so we will write again 4, 8. Okay, this is for expiration, this is for inspiration. Okay, inspiration, meaning that this is the amount of air that is entering in your lung. Okay, this is the amount of air that is entering in your lung, and expiration is the amount of air that is leaving your lung. Okay, so that's that. Are we all clear about this? Are we all clear about the labelings? Do we have any confusion? Do we have any confusions? Okay. So let's see what the normal flow volume curve is. So the normal flow volume curve is that, do you guys remember how in hysteresis, we talked about the fact that it's harder for the lungs to inflate than it is to deflate? Yes, okay. So and that is hysteresis, because the lungs have to work towards a certain surface tension. So what you have is, you have this inspiration. Okay, one second. So you have this inspiration over here. Okay, so you are inspiring air. Okay, and we know that there's 6 liters of right, 6 liters. So normal will be 2 to 6 over here. So this is the amount of air you inspire, and then the amount of air that you expire is like this. Okay, this is the normal flow which happens. Okay, this is the normal flow that happens over here. So this is how we are breathing right now. This is our flow volume loop. Okay, now let's talk about two types of diseases at first. Let's talk about two types of diseases at first. First of all, let's talk about obstructive disease, and let's talk about restrictive disease. Okay, let's talk about obstructive disease and restrictive disease. What happens in obstructive disease is you have a difficult time letting go of the air. So you have difficulty in expiration. And what happens in restrictive disease is you have a difficulty in inspiration. Okay, so it's more or less the opposite thing. So examples of obstructive disease are, for example, chronic obstructive pulmonary disease. And examples of restrictive disease are, for example, pneumoconiosis or pulmonary fibrosis. Okay, are we well acquainted with this piece of knowledge? Are we well aware of this piece of knowledge? Yes? Okay. Okay. So if we can draw the table, let's draw some information. Before we do that, okay, before we do that, this is the amount of air. Okay, first of all, this is the amount of air from 0 to 2. This is the amount of air which stays inside the lungs regardless. Okay, so this is your residual volume. Okay, this is your total lung capacity, 0 to 6 liters. And this is your vital capacity. Okay, are we clear about this? Are we clear about this? Are we clear about these labelings? Yes or no? Okay. Question, yes, what is your question? What is your question? Do we have any questions before we move forward? Because we have to finish this, guys, please. So please just let me know the questions. The numbers are on the vertical line. Are they in second? Yes, they are in second. Okay, liters per second. Liters per second. Can you please repeat? Yes, I can repeat. Once again, you have the flow volume loops. This is the liter. This is the amount of air coming per second. This is inspiration, meaning air is coming in. Okay, and this is expiration, meaning air is going out. Inspiration is an active process, so you are taking the air in, so air is coming inside. As a result, what happens is this is more or less like a negative vacuum that is created inside the lung. So this is down, and expiration is a passive process, so air is passively being released. So this is a positive gradient, negative gradient. That's that. And this is the horizontal, which is the x-axis. Over here, you have the liters. The anomaly is the liters are labeled from 0 to 8 this way because it's easier to make the graph accordingly like this, or else the whole thing would be inverted. Okay, so that's that. That's the only anomaly. This is the normal flow volume curve where you inspire, and the inspiration is an active process and it's a harder process than expiration. That's why the volume loop curve over here is shorter. Expiration is a harder, I mean, it's an easier process. So that's why this volume is longer over here. Okay, so this is easier to do. So that's why this is the one that is up over here. After drawing this is the amount of air that stays inside the lungs regardless, which is the residual volume. This is the amount of air which you breathe in and breathe out. So this is your vital capacity. This is the maximum amount of air which you can breathe out after a maximum inspiration. And this is the total amount of air that is remaining in the lung. In the normal human, it's 0 to 6 liters. This is your total lung capacity. Till now, this is all I have discussed. Okay, are we clear? Okay, next one. Now, we will talk about obstructive and restrictive disease. Once again, obstructive disease, is there a problem with expiration or inspiration? Obstructive disease, is there a problem with expiration or inspiration? Expiration. If there's a problem with expiration or expiration, what would happen to the residual volume? Will it be increased or decreased? Residual volume, what would happen to the residual volume? Would be increased or decreased? Residual volume would be increased. Okay, what would happen to the functional residual capacity? If the residual volume is increased, then the functional residual capacity should also increase. Am I correct? Yes or no? Fast answers, please. If the residual volume increases, then functional residual capacity should also increase, FRC. So functional residual capacity should also increase. So FRC is also increased over here. Okay. What would happen to the total lung capacity? Total lung capacity. If there is more air stuck inside the lung at all period of time, the lung will always stay expanded. So the total lung capacity will always be higher. So TLC would be higher. TLC would be higher. What would happen to the vital capacity? What would happen to vital capacity or FVC? What would happen to FVC? FVC would be decreased. Okay. What would happen to FVC? Functional vital capacity, FVC would be decreased. And there's another thing which we will discuss later, that is FEV1 to FVC ratio. FEV1 to FVC ratio. Okay. FEV1 is forced expiratory volume in 1 second. This is decreased, and FVC is also decreased. Okay. FVC is also decreased, but FEV1 is more decreased than FVC. As a result, total FEV1 to FVC is decreased. Okay, we will discuss this in details a bit later, but this is all the information we need. Okay, so right now, if we use this information to draw the graph for the obstructive ones, if we want to take this information and we want to draw the graph for the obstructive one, so for the obstructive one, if the residual volume is increased, then Shouldn't the graph start from over here instead of over here? Yes or no? Because the residual volume is now increased, it would be at least up to here for the obstructive ones. Yes? Yes. So it will start from over here. Okay. And then what do we talk about the vital capacity? The vital capacity, uh, for example, this has decreased. Okay. This has decreased. So for example, this should go and this should not stretch a lot. This should stay more or less over here. Okay. Then what would happen? Then the thing is expiration. The amount of expiration, we said that in obstruction, expiration is decreased. Yes or no? In obstruction, expiration is decreased. Yes or no? Yes or no? Okay. Obstruction, expiration is decreased. So if it's 8, we will keep it up to here, for example, 4. Okay. And then what about inspiration? In inspiration, since there is more air that is stuck inside the lungs, can you inspire more or should you inspire less? Because it's already filled up with air. So the inspiration should also be decreased. Okay. Inspiration should also be decreased. So somewhere over here. So right now, if you want to complete the graph, there should be something like this. Okay. So basically, in obstructive disease, the curve has shifted to the left because the residual volume is increased. Am I correct? Does that make sense? Okay. Okay. Next one. Next one is in restrictive disease. What happens in restrictive disease? What happens to the residual volume? Is it increased or is it decreased? Because right now there is not much air that is coming inside the lung because restriction is problem with inspiration. Okay, you cannot inspire. So with restrictive, the residual volume has decreased. What happens to the functional residual capacity? Residual volume is decreased, so functional residual capacity is also decreased. Since the total amount of air that is coming inside the lungs has decreased, as a result, total lung capacity has also decreased. Total lung capacity has also decreased. Look how over here the total lung capacity has increased, right? From over here all the way to over here in case of obstructive disease, the total lung capacity has been increased. But in restrictive disease, the total lung capacity is decreased, right? And then the forced vital capacity has also decreased over here, more or less, okay? So if we draw the diagram for restrictive disease right now, the residual volume, if we have to draw the, okay, 1 second. Okay. 1 second. Okay, this is for the obstructive disease, and now this is for the restrictive disease. For the restrictive disease, right now, if we want to draw this, then everything has decreased. Okay. So the residual volume over here should now start from over here. Okay. Am I correct about the residual volume point on the graph? Yes or no? Residual volume point in the graph. Will it start from over there? Am I correct? Yes or no? Guys, am I correct about this point over here for restrictive disease? Okay. So the residual volume has decreased. What about the total lung capacity? The total lung capacity should not be more than this one. So total lung capacity is also decreased. Okay, so the total lung capacity should be over here. Are we clear? Yes or no? Are we clear? Okay. Then what about inspiration? Inspiration is also decreased because in restrictive disease, you cannot inspire a lot of air, right? So the inspiration should be over here, right? And if you inspire less, should you expire less too? Yes or no? Less than normal? Okay, so if you inspire less, you should expire less than normal too. So it should be over here. So now, right now, if you complete the graph, it should be something like this. Okay. So this is your graph for restrictive disease. Basically, if it's an obstruction, the graph will shift to the left. Okay. For obstruction. If it's a restrictive disease, the graph should shift to the right. Are we clear about this? Have we all understood this one? Okay. How can it be possible that the others are increased except, okay, well, one second. Why is residual volume decreased? Residual volume is decreased because restrictive lung disease, in restrictive lung disease, residual volume is decreased because you cannot inspire air at all. You cannot inspire air, and the lungs, they cannot inflate, meaning that the lungs, they cannot stretch. Okay, so as a result, the residual volume is decreased, meaning less air can stay inside the lungs. Okay, that's why residual volume is decreased. In obstructive disease, the lungs are more stretched and hyperinflated. For example, in chronic obstructive pulmonary disease, there's hyperinflations of the lungs. So that's why the lungs are always stretched. So that's why residual volume is increased in obstructive disease and decreased in restrictive disease. Are we clear? Are we clear about this? Okay, you are welcome. Has everyone understood this one? This this curve? Okay, Dr. Grabasi, what is your confusion? Okay. Would you be kind enough to unmute yourself and ask me the question, please?
This morning, we know that ERV is decreased, so but that RV is increased. I understand, but the others, for example, the ERV is part of them. So how it can be that they are increasing if ERV is decreasing? That confuses me a little bit.
First of all, what is ERV?
It's like the
Expiratory reserve volume.
Right.
Can you define ERV, please?
Like how much lung will be, like how much air will be still in the lungs after normal expiration.
Expiratory reserve volume, meaning that the amount of air that is staying inside the lungs. Okay. Expiratory reserve volume is basically the air that can be still breathed out after a normal expiration, meaning that after you take a normal expiration, the amount of air that can be breathed out. So the thing is, expiratory reserve volume has very little to do with these things over here. The main thing that we are focusing on over here are three lung volumes, not ERV. We are focusing on residual volume, vital capacity, and total lung capacity. These are the only things that we are focusing on. Let me answer your question with ERV in 1 second. If we focus on these three things, first of all, the only thing that can help you with these curves are residual volume. If you can identify that with obstructive disease, residual volume is increased, then you can properly identify that the curve is shifted to the left. If in restrictive disease, you can identify that less inflation of the lung, so the residual volume is decreased, so you can identify the restrictive volume curves. Now, after that, the next thing that you have to identify is the total lung capacity. That is whether the graph should be a fat or a thin graph. And we know that in obstructive disease, it's a fat graph, meaning that the total lung capacity increases in obstruction because there's more air stuck inside the lungs. So the lungs are stretched more. So that's why you have the capacity, which is this high. And then in the restrictive, the exactly opposite thing occurs. After discussing everything, if you want to focus again on expiratory reserve volume, this is basically the air that can be breathed out after a normal expiration. So what happens is the ERV in obstructive disease, since there is a problem with breathing out of air, ERV in obstructive disease should be high, and ERV in obstructive disease should be low, and ERV in restrictive disease more or less should be low too, more in the sense that in restrictive disease, you are breathing in less air by itself. So if you're breathing in less air, then you're expiring less air. So we usually consider ERV when we draw the flow volume curves, but
Mm-hmm.
if we consider them, then we can identify that both of them are usually decreased in obstructive disease and restrictive disease. Does that make sense?
Yeah, makes no sense. Yeah, and force vital capacity is decreasing both, right?
Yes, the force vital
Okay.
capacity is decreasing in both cases. Okay,
Okay.
but the only thing that is different is residual volume. Residual volume is increased in obstruction and decreased in restrictive disease.
And that's the only thing which I have to mention. Okay. Thank you.
Which you have to remember. Okay, you are welcome. Okay, next one. Dr. Khatun, inspiration is decreased. What about expiration? Expiration is decreased in obstruction. Expiration is also decreased to some extent in restriction because less air is coming in. As a result, less air is going out. Okay, are we clear? Okay, okay, you guys are welcome. Thank you. Have you guys understood this one? Have you guys understood this curve? Okay. Okay, so right now, after since we have understood this, let's move back to our text to make sure we have studied everything. Okay, so this is the thing that we just discussed, flow volume loops. We discussed about the parameters, that is residual volume, which is increased in obstruction, decreased in restriction. Functional residual capacity, we discussed this too, total lung capacity. FeV1 to FVC ratio is something which I want to discuss right now, if you will. FeV1 to FVC ratio. Okay, what happens in FeV1 to FVC is forced expiratory volume in first second, meaning that in obstruction, what you have is you have obstruction of air which cannot leave the lung. As a result, more air stays inside the lungs. So in 1 second, you can actually let out less air, meaning that in restriction, you also have less expiration. This less expiration is because less air is coming in, not because there is an obstruction. So FEV1 in restriction is decreased 1 time, but more there is a further decrease in obstruction when compared to restriction of FEV1. So FEV1 in obstruction is decreased 2 times, meaning that there is a clear-cut obstruction of the air which cannot leave the lungs. As a result, the air stays inside the lungs for a longer period of time. And over here, the expiration is decreased because less air is coming inside the lungs. Okay, so FEV1 is decreased twice as further in obstruction. And forced vital capacity, in forced vital capacity, it's decreased in equal amount in both restriction and obstruction, meaning that over here it's decreased more or less 1 time. Okay, so if I have to do FEV1 to FVC ratio, okay, FEV1 to FVC ratio, since the numerator is decreased way more than the denominator, what would happen to the overall ratio? Should this be increased or decreased? Should this be increased or decreased? If the numerator is increased twice as much than the denominator, then the overall FEV1 to FVC ratio should be decreased. Very good. Good answer. Very good answer. Over here, if the numerator is the same as the denominator, what would happen to the FEV1 to FVC ratio? Should this be normal? Yes or no? Or the same? It should be normal. Or, or if the FEV1 is decreased less than FVC, meaning that um, meaning that the numerator is actually bigger than the denominator, meaning that the FVC right now is decreased way more than the denominator, because in inspiration, restrictive disease is an inspiratory disease, so expiration should not be hampered that much. The only reason why expiration is less is because you are breathing in less. There is no obstruction. So FEV1 should be less, but FVC is way more less compared to FEV1 because FVC is forced vital capacity. You cannot really inspire and expire as much because there is restriction. For example, in cases of pulmonary fibrosis or pneumoconiosis, you have restriction of lung movement, right? So can I say that there's a possibility that over here right now, it could be normal, or the the denominator is decreased way more than the numerator? Can I say that? Is that a possibility? Yes or no? Yes. So if I do say that, can I say that FEV1 to FVC can be normal or increased in restrictive lung disease? Okay. So FEV1 to FVC is normal or increased. So good answer. So next time, if you want to identify an obstructive disease or a restrictive disease, can you conclude that FEV1 to FVC ratio, if they mentioned this in the question, that FEV1 to FVC ratio is decreased, can you conclude that the disease they're talking about is an obstructive disease? Yes or no? For example, COPD, asthma, foreign body aspirations, right? And if they tell you that FEV1 to FVC is increased or normal, then can you conclude that the disease is, for example, pulmonary fibrosis, pneumoconiosis, ankylosing spondylitis, okay? Then rib fracture, that is restrictive lung diseases. Can you conclude that? So can you please remember that FEV1 to FVC ratios will be used for you to identify what type of disease you're dealing with. If it's increased, it's restrictive. If it's decreased, it's obstructive, increased or normal. Okay. Are we clear? Can we repeat why it's increased again? It's increased because the FVC is decreased way more than FEV1. FVC is decreased way more than FEV1. As a result, since the denominator has decreased more than the numerator, it could be increased, or if it's the same, then it will be normal. Forced vital capacity is basically the maximum amount of air. Can we define forced vital capacity? Do you want me to define or make you understand? Forced vital capacity. Forced vital capacity, FVC, is basically, this is the maximum volume of air that you can expire after a maximum inspiration forcefully. Forcefully, meaning that, for example, if you try to take a deep breath in and you try to take a deep breath out and you try to force it out as strongly as possible. For example, if you have a birthday cake over here, okay, and you have a candle on the birthday cake, okay, you want to make sure that you want to blow the candle, okay, you want to make sure that you blow the candle out, right? You want to take a deep breath in, okay, you want to take a deep breath in, and then you want to take a deep breath out maximally. The maximum amount of air that you can push out to blow the candle is known as forced vital capacity. That is forced vital capacity. Okay. FVC is equals to VC. No, FVC is not equals to VC, because vital capacity is not forced. This, for example, if this is the maximum volume of gas that can be expired after a maximum inspiration without force. If you use force, that's a forced vital capacity. Okay. If you induce, meaning that if you use the force to let out more air, then it's forced vital capacity. Okay, it's basically the same thing, but there's one where you apply force, another one is where you don't apply force. Okay, are we clear about this? One is with force, another one is without force. Are we clear? Okay. Okay. So have we understood the restrictive and obstructive lung diseases? I mean the flow volume curves for restrictive and obstructive disease. Okay, which one did you not understand, Dr. Hossam? Can you please unmute yourself?
Yes, dear. If forced expiratory volume is limited to time, yes, we measure it during special time, yes, 1 second. Is it the same? Yeah.
Yes, FEV1 is measured in 1 second.
Is it the same for forced expiratory volume? Is it the same
Yes,
for
it's
forced
the same
vital
as forced
capacity?
expiratory volume. Yes, it's the same as forced expiratory volume, but we do not mention forced expiratory volume in 1 second. If we measure it in 1 second, then we call it FEV1. If we measure it in 2 seconds, we can say FEV2. In 3 seconds, FEV3. So 1 is basically meaning in 1 second. That's that.
Sorry, forced vital capacity. Is it the same also within 1 second?
No, forced vital capacity is not in 1 second. Forced vital capacity is measured in a spirometer. In a
Okay.
spirometer, what you get is, let me show you what a spirometer is. 1 second. In a spirometer, okay. In a spirometer like this one, okay, you take a deep breath in as forcefully as possible, and you try to use your diaphragm and your chest muscle, okay, to force the air out as strongly as possible through this, and then they measure it over here. This is known as forced vital capacity. Okay, and normal vital capacity is if you involuntarily take a deep breath and you take a deep breath out, that is known as vital capacity. So the difference between forced vital capacity and vital capacity is the use of the respiratory muscles. Okay. Any other confusion? One second. What is the difference between FVC and VC? FVC and VC means it's the same thing. One is without the use of respiratory muscles, another one is the use of respiratory muscles. Okay. Are we clear? Are we clear about this? Can I get some yes or no so that I can move on or not move? So what is the difference between FVC and VC? Let me ask you now. What is the difference between FVC and VC? What the difference between FVC and VC? Use of respiratory muscles and extra respiratory muscles to let out excessive air or breathe in excessive air. Okay, are we clear about this? Okay. Is everyone clear? Okay. Next time, if you guys receive a question in UWorld where they talk about a disease where FEV1 to FVC ratio is decreased, and you have a graph which looks something like, this. Okay. What are the types of diseases you will think about? FEV1 to FVC ratio is decreased and the graph looks like this. What are the types of diseases you will think about? Okay. If FEV1 to FVC ratio is normal or increased and you receive a graph which looks like this, what are the types of diseases you will think about? Restrictive disease. Restrictive diseases. Okay. Okay. Have we all understood this? Okay. Okay, very good. So can we move on to obstructive lung disease and restrictive lung disease? Or do you guys want to take a 5-minute break before we do that? What about graph of tracheostenosis? Okay, we will talk about the other graphs too when we come to the discussion of the pathology. We will talk about those other graphs. Okay, let's take a break for how long? How long do you guys want to take the break? 10 to 15 minutes. So do you want to start at 11? Okay, all right. Okay. So let's start at 11. That's what we're going to do. Let's take a small break for 10 to 15 minutes. All right. Okay, is everyone back from their break? Is everyone back from their break? Okay, perfect. So are you guys understanding the respiratory pathology properly? Because right now we will jump into the disease portion. Okay, very good, very well. How do we feel about the respiratory system? Do we feel confident? Okay. Have you guys done questions regarding the respiratory system? Have you guys done any questions from the world, from the respiratory system? Okay. Okay, good. So let's begin with the next one. The next thing that we want to talk about is obstructive diseases, obstructive lung diseases. Okay. Obstructive lung diseases that we want to talk about is basically um, what we will do is we will talk about the diseases in the blank page, and then we will come back to each and every disease and make sure that we have targeted all those things. Okay, so that's what we're going to do. Okay, so first and foremost, obstructive lung diseases are basically obstructions of airflow, right? They're basically obstructions of airflow where the air is trapped inside the lungs. Okay.
Doctor, the
Oh,
screen, please.
oh, my apologies. I'm sorry. I'm sorry. Okay. So what happens is obstructive lung disease is basically obstruction of airflow where the air is trapped inside the lungs. Okay. And what happens is over here, the airways, they close prematurely at high lung volumes. So the airs, they close prematurely, then the things that we discussed a bit earlier, that is residual volume, lung capacity, functional residual capacity, all of these things will be increased over here. The things that will be decreased are FEV1 to FVC ratio and FEV1 to FVC. We discussed about them. Do we have any confusion regarding these findings, yes or no?
Excuse me, doctor, there are some background noises.
Okay. Can we have a student? Do we have any student with background noises over here? Okay. Is the noise clear right now? Can you guys hear my voice? Okay, good. So what we were talking about is obstructive lung disease. Over here, what you have is functional residual capacity, residual volume, and total lung capacity, and all of those things are increased. Do we have any confusion regarding this one? Residual volume, total lung capacity, and functional residual capacity, the fact that they're all increased? Okay, no. And another one is FEV1 to FVC ratio is decreased over here. And FEV1 to FVC ratio, we talked about them and how they're decreased, and we also did that. So try to understand that this is the hallmark of obstructive diseases. That is FEV1 to FVC ratio being decreased is the hallmark of obstructive disease. And the exact opposite will happen in restrictive disease. That's either it will be normal or it will be increased. If we have an obstructive disease, meaning that over there, if we talk about VQ, meaning ventilation and perfusion, okay, the perfusion can be maintained, but the since there is obstruction, meaning that the ventilation is not there, so there will be a VQ mismatch for obvious reasons, meaning that the ventilation is not matching the perfusion. It will be less than 1, okay, because the ventilation will be decreased, perfusion will be more or less okay, so it will be less than 1, and we know that we need 1 for proper adequate ventilation. Okay, that's that. In chronic hypoxic pulmonary chronic hypoxic condition, pulmonary vasoconstriction can lead to core pulmonary. Pulmonary vasoconstriction can lead to core pulmonary. Do you guys remember we talked about this before, that that the lungs have a very special mechanism, that is in one part of the lungs, if they undergo hypoxemia, there will be a vasoconstriction and on the blood will be pushed toward the well ventilated area. If this keeps on happening for a long period of time, what this will do is this will create pressure in the lung, in the pulmonary vascular beds, and this will increase the resistance, and this will mean that the right heart would have to work more to push the blood out to the lungs, and this can result in right heart failure. Right heart failure due to lung causes is known as core pulmonary. Okay, next one. So what are the types of restrictive diseases that we want to talk about? The types of restrictive diseases that we want to talk about are chronic obstructive pulmonary disease, which includes a couple of diseases by itself, which is chronic bronchitis, emphysema, and then it also contains asthma. Asthma is not a chronic obstructive pulmonary disease, but the findings of asthma are more or less the same as COPD. Okay, because in asthma you have bronchoconstriction, which can cause the sign symptoms. So that's that. So what we're going to do is we're going to move into this table, and we will talk about the presentations, pathology, and how we can diagnose these conditions according to USMLE step 1. And first of all, this is extremely high yield. So let me just put my stars over here. Okay. Please don't forget these lung capacity volumes. FEV1 to FVC ratio is decreased. FRC, RV, and TLC is increased. And that's that. Okay. So what we're going to do is we're going to jump into the diseases in our blank page over here. So we're going to start with COPD. COPD consists of chronic bronchitis and emphysema. So we're going to talk about chronic bronchitis first. So in chronic bronchitis, CB for chronic bronchitis, what you get is, let's talk about the pathology first. What's happening over here? Chronic bronchitis. The number one reason for chronic bronchitis and emphysema, that is COPD, there are basically two reasons on a broad spectrum why these things can happen. Number one is smoking. Number two is alpha-1 antitrypsin deficiency. Okay, so first of all, let's talk about the pathology. That is, what's happening over here is that, do you guys remember that when we talked about the epithelial layers? One second. Okay, when we talked about the anatomy, one second, just give me 1 second, please. When we talked about the anatomy, we talked about the fact how there are goblet cells and smooth muscle cells. They contain the goblet cells, and the goblet cells are basically present in all the layers of the conducting zone, more or less, because the conducting zone, the goblet cells, this is the picture I want to talk about. The goblet cells that are over here. Do you guys remember we talked about the fact how the goblet cells are responsible for the secretion of mucus, and the mucus secretion, it traps the foreign particles, and then the cilia beats back and forth to move the mucus all the way up, so to either cough it out, sneeze it out, or uh, swallow it in the esophagus. So what would happen over here is, in chronic bronchitis, if you have exposure to cigarettes for a long period of time, or to dirt for a long period of time, your goblet cells, what they will do is they will try to increase in number, because right now you are exposing your goblet cells to a lot of dirty substance and dirty particles. So what would happen is, over here you will have hypertrophy, and hyperplasia. You will have hypertrophy and hyperplasia of these cells, of these goblet cells. So instead of the goblet cells being 1 or 2, there will be a lot of goblet cells over here. There will be more goblet cells, hypertrophy and hyperplasia. So if there's more goblet cells, what would happen over here is that there will be increased amount of mucus secretion. So the mucus secretion will increase, so increased mucus secretion. And over here, the patients, they will usually complain for the fact that the mucus secretion is so much that they are coughing out and secreting buckets of mucus every day. Buckets of mucus, so much mucus that there is buckets of mucus, meaning that if you keep a bucket near a patient of chronic bronchitis, by the end of the day, that full bucket will be filled with mucus, because that's what's exactly happening over here. So in a clinical setting, if you want to identify the hypertrophy and hyperplasia, okay, what we want to do is we want to calculate a very important thing, that is Reed's index. Reed index basically means thickness of mucosal gland, thickness of mucosal gland thickness of the mucosal gland layer to the entire thickness of epithelium and cartilage. So if we try to identify the Reed index in this drawing over here, okay, so the thing is, this is the thickness of the mucosal gland. Okay, so the thickness of the mucosal gland is basically, let's say that this is the thickness of the mucosal gland, or let's do it over here. thickness of the mucosal gland, okay, to the entire thickness of the epithelium and the cartilage. The ratio of this one to this one is known as Reed's index. The ratio of this one to this one is known as Reed's index. And if this index, if this Reed index, if this is more than 50%, then this is diagnostic of chronic bronchitis. Are we clear about this? Are we clear about this? Yes or no? Okay. Reed index. Once again, Reed index. Let me show you. Okay. Look at this diagram. Okay, look at this diagram. Reed index. Reed index basically means that this is basically the ratio of the amount of the mucosal gland, the submucosal gland, to the total ratio between the epithelium and the cartilage. So this is the one. So over in the Usmle step 1, you will receive this exact diagram over here. You will receive this exact diagram over here. They will ask you to identify the Reed index by looking at this one. Over here, I did this one. I selected this one because over here, this is where the goblet cells are. Over here, they did not identify the submucosal gland. So I took this one as into consideration. But if you have a diagram like this, then this should be the Reed index, that is the amount of goblet cells to the total layer between the epithelium and the cartilage. And over here, if you receive these type of questions, then that should be the area between the epithelium and the cartilage divided by the submucosal glands divided by this layer. And this AB by CD, this type of presentation for Reed index is very high yield for Usmle step 1. Okay. And why is this happening? This is happening because in a normal person like me and you, our submucosal glands are normal, okay, because we are not exposing them to cigarettes. But in patients who are chronic smokers, they have exposed their lungs to so much cigarettes that their mucosal glands are hypertrophied to secrete more mucus. So their Reed index should be way more than us. If it's more than 50%, then it's diagnostic of chronic bronchitis. Are we clear about this? Yes or no? Are we clear about this? Okay. Okay. So please do not forget this picture. Do not forget this picture. Reed index is submucosal gland divided by the area between epithelium and cartilage. Okay. Are we clear about this one? You guys will receive this question in UWorld 100%. 100% you guys will receive this question. Okay, so be careful. Okay, so that's that. Okay, next one is what are the X-ray findings? Okay, X-ray of chronic bronchitis. Okay, X-ray of chronic bronchitis. Let's look at the X-ray. What happens is that in X-ray, if you see an X-ray of chronic bronchitis or COPD, you see a couple of things. What do you see? In X-ray, you see that the lungs are stretched out. So there's hyperinflation of the lungs, and then hyperillumination, meaning that air is trapped. So it's more darker than usual than a normal lung. Okay, let me show you a normal lung X-ray. Okay. Okay. So this is an X-ray of a normal lung, more or less. Okay, this is an X-ray of a normal lung, more or less. Although there might be some fine, but these are scapular regions. But this is a normal X-ray. Look at how this X-ray is more darker than this X-ray. That's because this lung is hyperilluminated or transilluminated. So meaning that air is trapped over here. And look at how there is a shape of the lung. That is this one over here showing normal inflation. Over here, you can see that there is a hyperinflation. There is a hyperinflation. To some extent, look at the shape of the heart. The shape of the heart over here is normal, but look at how the shape of the heart over here is narrow or somewhat of a bob shape or like a vertical heart shape. Okay, because what's happening over here is that the lungs are stretched out so much that they push the heart from both sides. That is from this side and from this side, that they push the hearts, and the hearts take a more vertical appearance over here. And to some extent over here, you can see that there's a tracheal deviation. The trachea has deviated to either this side or it's being pushed away from this side, depending if there's a collapse. So tracheal deviation could mean lung collapse, but tracheal deviation is not present in COPD a lot of the time. The only things that are present are hyperinflation, hyperillumination, and vertical appearance of the heart compared to the normal X-ray. That's what you find in a patient of chronic bronchitis, more or less. And also, these are the types of X-ray, more or less, that are found in emphysema, so COPD as a whole. Okay, that's that. Now, if we talk about the clinical features of these patients, what are the clinical features? Clinical features of these patients, what they will present is shortness of breath. Okay, they will present with shortness of breath. Then what do they have? They will have wheezing. To some extent, since there is excessive mucus production, there should be crackles in the lung. Wheezing, crackles. And these patients should have carbon dioxide retention. So they should have their partial pressure of carbon dioxide is always increased. Have we heard about this piece of information that in patients of COPD, we're not supposed to give high flow oxygen? Have we heard this piece of information? In patients of COPD, you are not supposed to give high flow oxygen. Can anyone tell me why we're not supposed to give them high flow oxygen? Can anyone tell me why we're not supposed to give patients of COPD high flow oxygen? Right. What happens is patients in COPD, their partial pressure of carbon dioxide is the one which is always increased. So partial pressure, so the carbon dioxide is the main respiratory stimulator. Partial pressure of carbon dioxide is stimulating the respiratory center to maintain the breathing patterns. In a normal human, oxygen is the one which is responsible for maintaining the respiration, but in COPD patients, partial pressure of carbon dioxide as a whole is responsible for maintaining the respiration. So in these patients, if you give them high flow oxygen, the carbon dioxide will decrease and oxygen will increase, and this sudden change will desensitize the brain to partial pressure of carbon dioxide, and the brain can stop sending signals to the lungs to cause respiration, and there can be a sudden respiratory arrest, and the patient can die of respiratory failure. So as a physician, always remember that you are not supposed to give the patient of COPD high flow oxygen. You are always supposed to maintain a low flow of oxygen for patients of COPD. Okay, so do not forget that. Okay, so these patients, they have increased carbon dioxide retention. Okay, increased carbon dioxide retention. And along with this, for a high period of hypoxemia, what they have is they have increased erythropoietin and secondary polycythemia. They have erythropoietin and secondary polycythemia. Okay. Another one is diagnostic criteria on a clinical setting. These patients will have productive cough. These patients will have productive cough for more than 3 months, 3 or more months in 1 year for 2 straight years, meaning that these patients, for example, they will have these type of coughing and mucus production from January to let's say April in the year 2020 and 2021. If you have any patients like this sorts of presentations where they have productive cough for 3 or more months, where there's excessive production of mucus, and it's continuing every year for a consecutive of 2 years, then these patients can be clinically diagnosed as chronic bronchitis. Okay, are we clear about this? Are we clear about this? Okay, okay. Can you guys, okay, now let's read, so can you guys read with me the first aid? Okay, let's see what the first aid says. Okay, 1 second. Let's find out what the first aid says. Okay. So in chronic bronchitis, the presentation, 1 second. Okay. In chronic bronchitis, the presentations, you can find that these patients, they have wheezing, crackles, cyanosis, dyspnea, carbon dioxide retention, and secondary polycythemia, which we just talked about. Pathology is hypertrophy and hyperplasia of mucus secreting glands. Then we talked a little bit about read index. So do not forget about read index. That is thickness of the submucosal glands to the entire thickness between the epithelium and the cartilage. So that's that. That has to be more than 50% over here. And the diagnostic criteria is productive cough for 3 or more months in a patient for more than 2 consecutive years. And we also talked about the X-ray. That in the X-ray you will see hyperinflation, hyperillumination, and a vertical appearing lung. Okay. Are we clear about this? Are we clear about this? Are we clear about chronic bronchitis, guys? Hyperinflation, hyperopacity, and vertical appearance of the lungs. Okay. Is there shunting due to VQ mismatch? What type of shunting are you talking about? Would you please explain? In chronic bronchitis, what like in hypoxemia due to shunting? Oh yes, meaning that, are you talking about the blood being shunted from a low ventilated area to a more ventilated area? Is that what you're talking about? From a low ventilated area to a more ventilated area? Is that what you're talking about? No, what type of shunting are you talking about? Okay, 1 second. Let me see. Hypoxemia due to shunting. Oh, exactly. That's what it means, meaning that the blood is shunted from a low ventilated area to a more ventilated area. That's what this means. Okay. Are we clear? Okay. Next one is DLCO. DLCO basically means diffusing capacity or transfer factor of the lung for carbon monoxide. This is the extent to which the oxygen from the air of the lung reaches into the blood. Okay, meaning that the amount of oxygen that from the air it reaches into the lung, meaning that the diffusion of oxygen, this remains the same. DLCO is usually the same. DLCO is usually the same. Okay, this is not high yield. If it was high yield, I would have mentioned it. Are we clear about this? Okay. Okay. So diffusion capacity of the oxygen remains the same. Okay, next one. Next one that we want to talk about is emphysema or pink puffers. Okay. So before we talk about emphysema, emphysema is once again another type of chronic obstructive pulmonary disease. Emphysema, the findings in emphysema are more or less what you will find is you will find a patient with a barrel-shaped chest. So barrel-shaped chest basically mean that if the patient is like this, okay, that the shape of the patient will be a barrel-shaped, that there will be increased AP diameter, barrel-shaped chest, and exhalation through pursed lips. These patients, what they will have is they will have pursed lip breathing, meaning that if this is the lip, okay, if this is the lip, okay, for example, if this is the lip over here, these patients will have their tongue sticking outwards over here, and they will breathe in through this way. What this will do is this will create a type of continuous positive airway pressure, CPAP. This is a type of CPAP. What will happen is when they try to leave through the mouth, they will get stuck on the tongue and then they will go back over here. So this will prevent lung collapse. So these patients, they will try to breathe like this because they will realize that breathing like this is easier, because in this way, this increases the airway pressure and this prevents the lung collapse or airway collapse, meaning that the excess amount of air cannot leave when the patients breathe like this. So the air stays inside and it prevents lung collapse. Let me show you a person that's breathing properly. Mhm. This is how they will breathe. Okay. This is how they will breathe. They will try to have their tongues over here and they will breathe like this. Okay. They will try to breathe like this so that extra amount of air stays inside the lungs to prevent the lung collapse. So if you see any patient who is breathing like this, there's a high possibility that these patients, they have emphysema. Okay. They have emphysema or any type of lung problem. Okay. Next one. Um, next one is the types of emphysema. Okay, if we have to talk about the types of emphysema, first of all, let's talk about the types of emphysema. That is, we have centri-ascinar emphysema, and then we have a pan-ascinar emphysema. Centri-ascinar emphysema is the one where in centri-ascinar emphysema, okay, centri-ascinar emphysema, you have in centri-ascinar emphysema, they will affect two things. One is they will affect the respiratory bronchioles. Another one they will affect is distal alveoli. So basically, they will affect the respiratory zones. Okay, so over here, as you can see that in centri-ascinar emphysema, they will have affected the, if this is a normal one, this is the respiratory bronchioles, and this is the distal alveoli. Distal alveoli, that is these ones over here. Okay, and these ones. These are the only things that are affected in central emphysema. In central emphysema, in centri-ascinar emphysema, centri-ascinar emphysema happens because of one thing only, and that is smoking. So the fact that centri-ascinar emphysema is connected to smoking, the way that you can try to identify centri-ascinar is you can spell centri-ascinar with an S, so S-E-N-T-R-I, centri-ascinar. Centri-ascinar for smoking. That's that. You will be asked what type of emphysema is more common in smoking, and the answer is centri-ascinar emphysema over here. Okay, and it frequently appears in upper lobe. It frequently appears in the upper lobes, meaning that the upper lobes of the lungs, they appear more. And the first aid uses the mnemonic that is smoke rises up. So if you smoke, the smoke will go up, and they will cause centri-ascinar emphysema in the upper lobes. That is centri-ascinar emphysema. Next one is pan-ascinar emphysema. Pan-ascinar emphysema is when everything from the respiratory bronchioles to the distal to the proximal alveolar sacs, everything is affected. And emphysema basically meaning that there is dilatation and enlargement. Meaning what happens is there's destruction of the septa over here. That you can see that the alveoli, they have septa. For example, if I have a balloon like this, they have septas like this, right? The alveolar septa. And this is what is creating this type of appearance of the alveoli, right? When you breathe out, when you breathe in, this is what's happening over here. But if you have destruction of these septas, okay, if you have destruction of these septas, then what the alveoli are is that they are nothing but this type of club-shaped structures. So these ones will expand more than these ones. So they cannot expand. As a result, these patients are hypoxic and they have shortness of breath. They are always dyspneic. So that's the main problem. So in pan-ascinar emphysema, you have affection of all the layers from the respiratory bronchioles to the distal to the proximal. So everything is affected over here. And pan-ascinar emphysema is common in alpha-1 antitrypsin deficiency. And alpha-1 antitrypsin deficiency. This is very, very high yield. That is, centri-ascinar is important for smoking, and pan-ascinar is important for alpha-1 antitrypsin deficiency. And the exact opposite thing happens, that is centri-ascinar is in the upper lobe and pan-ascinar is in the lower lobe. Okay, have we understood centri pan-ascinar emphysema? Yes or no? Okay. Okay, now let's talk a little bit about the pathology. The pathology is what happens over here is that you have enlargement of the air spaces, right? So before you had alveoli which look like this. Now after emphysema, you have alveoli which look like this. So what happens is this results in decreased recoil, and this results in decreased compliance. I mean, increased compliance, not decreased compliance. Compliance is increased over here. Although compliance is increased over here, but diffusion cannot happen, meaning that they can stretch, but diffusion is diffusionless. So compliance is actually increased over here. Compliance is increased over here. Another thing is the DLCO over there was not important, meaning the DLCO for chronic bronchitis was not important. As I mentioned, it was not normal. I mean, it was normal, but the DLCO from over here is decreased DLCO, meaning that the diffusion capacity of oxygen is decreased, because in the diffusion capacity is decreased because there's destruction of the alveolar walls. So you have decreased recoil, increased compliance, and decreased DLCO from destruction of the alveolar walls over here. Okay. And you also have decreased blood volumes in the pulmonary capillaries. Why do you have decreased blood volumes in the pulmonary capillaries? Once again, it's also due to hypoxemia. Due to hypoxia. In hypoxia, you have pulmonary vasoconstriction. So as a result, you have decreased amount of blood volume in the pulmonary capillaries. So that's that. And have we understood everything up to this? Have you understood everything up to this? Everyone? Diffusing lung capacity for carbon monoxide. But this is used as a parameter to see diffusion of oxygen. That's what I said. DLCO, diffusion limitation for carbon monoxide, but this is used as a parameter to see oxygen diffusion. Okay, the same thing. This basically means diffusion. Okay, they have a very annoying way of using a lot of terms which can confuse a lot of students. Okay, they have a habit of doing that, but this basically means nothing but diffusion. Okay. All right. Are we all clear about all the terms up to here? Are we clear about this? Okay, good. Now, if we are clear about this, then I want to discuss a little bit about alpha-1 antitrypsin deficiency. That is, in the lungs, you always need a balance between the protease and anti-protease, meaning that proteases are responsible for breaking down lung structures, and anti-proteases will break down the proteases so that not enough proteases will go and break down the lung structures. If you have more proteases than the anti-proteases, for example, in alpha-1 antitrypsin is an antiprotease. If we have antiprotease deficiency, we have so much protease that this protease, example elastase, what this does is this goes and it destroys the elastic septas over here. It destroys the elasticity of the alveoli. So this destruction of elasticity of the alveoli, what this does is this results in increase of lung compliance. What happens is, for example, you can think about this as, let's say, a piece of balloon and let's say a plastic bag. Okay, this is a plastic bag, and this is a piece of balloon. Which one has more elasticity? Which one has more elasticity? The balloon or the bag? Elasticity. The balloon has the more elasticity, right? But if I tell you that you blow air, now you blow, let's say you blow air for 10 seconds in the balloon and you blow air for 10 seconds in the bag. Which one will stretch more? Which one will stretch? Which one will stretch more? Stretching. Are you sure the balloon The bag stretch more because the bag is already stretched out. The bag is already stretched out. If you blow, the bag will blow like this, and the balloon can only stretch up to here for 10 seconds. Did you guys understand this concept? How loss of elasticity results in increased compliance? Once again, you have a piece of balloon, you have a piece of a plastic bag. Okay, you have a plastic bag over here. Okay, if you blow air into the balloon and you blow air into the plastic bag will expand easily because no force is over here. Okay, there's no force over here, but the balloons have an elastic force. The balloons have an elastic force which will pull the balloon inward. So it's easier to blow out a plastic bag than to blow out a balloon. Yes? Exactly. It already has air inside, so the stretching force can be smaller to reach the same result, meaning that the plastic bag, they have no elasticity, so they can be blown more. And the balloon has more elasticity, so it's harder to blow the balloon. So who has the better compliance, the balloon or the bag? Who can stretch more? Fast answers, please. Fast answers. I need some fast answers for you. Bag. Exactly. So this is the same mechanism. This is the same mechanism which is causing the emphysema. That in emphysema you have all these bag-like structures, but this was a balloon. Okay, so you have increased lung compliance, but the diffusion is not there. Okay, are we clear about this? Are we clear about this? Okay. Are we confident, guys? Can I get some more yeses and nos? We have understood this or not understood this? Okay, very good. The shunt they mean is the shunt from hypoxia. If there is a hypoxia, the blood is shunted from a low ventilated area to a less ventilated area. Hypoxia is general, but still it does not matter because some parts of the lungs will still be more ventilated than those parts of the lung. If the all over the lung is hypoxic, then throughout the whole lungs there will be pulmonary vasoconstriction and increasing pulmonary vascular resistance, and that's how you get right heart failure. Okay, that's how you get right heart failure. Next one. Why doesn't an enlargement of airway lead to a decrease in recoil? If the airways are increased, if the airways are enlarged, the airways are basically enlarged because there is law of elasticity. If there was increased elasticity, then the airways would not be enlarged. Okay, so that's why airways are enlarged in loss of elasticity. Next question. Sorry, got confused. Can you repeat the example with the bag? Yes, with the bag and the balloon is, in the balloon, the balloons have more elasticity than a piece of a bag. Okay, so let's say this is a balloon, this is a bag, this is a plastic bag. Okay, this is a plastic bag. Balloons have more forces this way, right? So if you have to blow air in, they have to overcome this force and they have to push the balloon out so that the balloon can expand like this. But plastic bags, they have no elasticity. Okay, they have no elasticity. So if you put a little amount of air, the plastic bag will blow up. But if you put that same amount of air in the balloon will not blow up. So this is what we mean about loss of elasticity and increase of lung compliance. So the balloon has more compliance, meaning more ability to stretch than the bag has the more ability to stretch than the balloon because the bag has no elasticity. Okay. Are we clear about this? Are we clear about this? This is the difference between an elastic lung and a non-elastic lung. A non-elastic lung is what happens in alpha-1 antitrypsin deficiency. So next time you think about alpha-1 antitrypsin deficiency, think about the patient's lung as a plastic bag. Okay. Are we clear? Okay. Next one. Next one that I want to talk to you guys about is next one that I want to talk to you guys about is asthma. Okay. Before we talk about this, look at how the chest X-ray finding in this one is the same as chronic bronchitis. That is increase in AP diameter, flattening diaphragm, and increase in lung opacity or increase in lung fluid translucency. The same thing over here. So you expect to find the same types of X-ray. That is hyperinflated, hyper opaque, and a vertical heart-shaped X-ray. Okay, that is what you expect to find over there. Next one is asthma. Asthma, what are the findings in asthma? In asthma, you have cough, wheezing. Does any one of the students over here today in our lecture, do they have asthma? Does anyone have asthma? Any, anyone else? Okay. Dr. Karbasi and Dr. Ibrahim, so would you be kind enough to tell us how do you feel when you get an attack? How do you feel when you get an attack? What are your symptoms? Guys, shortness of breath. Then what else? Do you guys get wheezes? Do you guys have increased heart rate and increased rate and depth of breathing? Okay, so cough, wheezing, tachypnea, dyspnea, and then what you have is you have hypoxemia, right? And then what another thing is you get decreased inspiratory to expiratory ratio, meaning that your expiratory ratio, if you do a ratio of inspiration to expiration, this ratio will be higher. I mean lower. This ratio will be lower. This is not high yield. This is not very high yield. Decrease inspiratory to expiratory ratio. What's high yield is FEV1 to FVC ratio. So focus on that ratio only. Okay. Next one is you will get pulsus paradoxus and mucus plugging. Can anyone tell me what pulsus paradoxus is? Pulsus paradoxus. Pulsus paradoxus. What is pulsus paradoxus? Increase in. Can you guys just give me 1 second? Just give me 1 second. Okay. So we were talking about pulsus paradoxus. Pulsus paradoxus is what happens is that what happens is there a decrease in blood pressure or is there an increase in blood pressure with inspiration? Which happens? Pulsus paradox, yes. So in these patients, what happens is when they inspire air, when they inspire air, they get pulsus paradoxus. That is, there is a decrease in blood pressure more than 10 with each and every inspiration. And you can expect to see this. Okay, and you can expect to see this in a patient with bronchial asthma. So that's that. So over here, if you can see over here that in these patients you have pulsus paradoxus, and then you also get mucus plugging over here. Okay, the mucus plugging. If you can see, this is the mucus plugging. Okay, this is the type of mucus plugging that you can see over here. Then there are some another things that we want to see in these patients. There are another things. First of all, these patients, what they have is they have an hyperimmune allergic response. They have a hyperimmune allergic response. What happens is when there is any antigen, for example, for patients of asthma, when they get exposed to an antigen, if it's a hyperimmune response, what they get is they can get smooth muscle hypertrophy and hyperplasia, right? Smooth muscle hypertrophy and hyperplasia. And before that, they can get bronchoconstriction, severe bronchoconstriction. So that's why in these patients, we use beta 2 agonists, for example, salbutamol, right? Because they go and they activate the bronchial smooth muscles, and that causes bronchodilatations. After that, what happens is over here you find two very high yield things. What are the two high yield things? Number one is Cushman spirals. What is Cushman spirals? Cushman spirals are this spirals over here. That is this one. These are basically epithelium shedding. You know, like how the lungs, they have epithelium, right? The lungs, they have epithelium over here, right? The alveolar epithelium of the lung, they shed out and they are spitted out with the coughs or sneezes. So you will see these type of spirals. These are known as Cushman spirals. These are very high yield for the diagnosis of asthma. Another thing that you can find over here are these ones, that is Charcot-Leyden crystals. Charcot-Leyden crystals over here. These type of crystals, what they are is they are this eosinophilic hexagonal eosinophilic crystal, and they have 2 points. They are double pointed crystals. And what they are is, you know, like how patients of asthma, they have high amount of eosinophils. Patients of asthma, they have high amount of eosinophils. These eosinophils, they break down and they form this sort of structure. So it's a eosinophilic hexagonal double pointed crystal like structure known as Charcot-Leyden crystals. These are the two things that you find in a patient with asthma. Along with this, you find mucus plugging, and then they also have hyperinflation and all those stuffs, right? So that's that. Over here, as you can see, that the DLCO is not important once again, because the DLCO is normal or increased, meaning that there is the diffusion is intact. Okay, so that's what we mean over here. Okay, so that's that. Now, the asthma that we talked about, it's a type 1 hypersensitivity reaction. Okay, how do we diagnose asthma? We diagnose asthma by patient presentation, meaning that the patients will come with shortness of breath, wheezing, dyspnea. All right, and along with this, they will tell you that they have other sign symptoms of allergy. For example, they can also have atopic dermatitis, showing that they have type 1 hypersensitivity. So that's that. And along with this, if you want to confirm, we can do X-ray, or we can do spirometer or by spirometry test, and methacholine challenge. What is methacholine challenge? Methacholine, what type of a drug is methacholine? Can anyone tell me what type of a drug is methacholine? Methacholine. What type of a drug is methacholine? Methacholine. Is it a parasympathetic drug or sympathetic drug? Parasympathetic, sympathetic. It's parasympathetic drug. Parasympathetic drugs, are they supposed to cause bronchoconstriction or bronchodilation? Bronchoconstriction is very, they are supposed to cause bronchoconstriction, but in normal individuals, when methacholine causes bronchoconstriction, you have us, a normal patient with a negative feedback. What this will do is this will cause release of more adrenaline, and then we would have reversible bronchodilation, so we will not realize the bronchoconstriction feeling. But patients of asthma, when you give them methacholine, they will have bronchoconstriction for a longer period of time. So this is called methacholine challenge test. And when you challenge a patient with asthma with methacholine, what this does is this causes bronchoconstriction for a longer period of time. And you can use methacholine to diagnose asthmatic patients. Okay, that's that. Another one is patients of asthma. If you give them NSAIDs are cyclooxygenase inhibitors. When you inhibit the cyclooxygenase pathway in an arachidonic acid metabolism, when you inhibit cyclooxygenase pathway, the pathway gets shifted to lipoxygenase pathway, where you have increased formations of leukotrienes and lipoxenes. And we know that certain leukotrienes, those leukotrienes causes severe bronchoconstriction. So if you give them NSAID, for example, naproxen, ibuprofen, and all these types of strong non-steroidal anti-inflammatory drugs, this will shift the arachidonic acid metabolism to this way, to the leukotriene pathway, and you will have overproductions of leukotrienes, and leukotrienes can cause severe bronchoconstrictions, severe bronchoconstriction. So that's that. Along with that, these patients can have chronic sinusitis, nasal polyps, and asthma. Okay, are we clear about this? Are we clear about this? Okay, treat a patient with asthma. How do you treat a patient with asthma? You have beta agonists, adrenalines, steroids, then anti-leukotrienes, then antihistamine, then mast cell stabilizers, right? A lot of drugs. You have a lot of different types of drugs which you can give to treat asthma. Okay, so these are the ones. Okay, muscarinic antagonist, right? Very good. Okay, so that's that. Once again, what is asthma? Asthma is basically a hypersensitivity reaction of the lungs, where the lungs are hypersensitive to allergens. When they come, they induce an type 1 immune response, type 1 hypersensitivity response, where there is bronchoconstriction. Bronchoconstriction, and the patients have cough, wheezing, tachypnea, hypoxia, pulsus paradoxus. And when the patients, you want to see the microscopic findings of asthma, you have three findings. First of all, there is mucus plugging, then you have Cushman spiral, and then you have Charcot-Leyden crystal. Cushman spirals are spiral-shaped shed epithelium, and Charcot-Leyden crystals are eosinophilic crystals, which are bipointed, and they are hexagonal in shape. And then once again, how do you diagnose patients? You can do an X-ray where you can see there's hyperinflation, then the increased increased the lung field opacity. That's that, right? And then you can also see a vertical shaped heart. Along with this, you can do a spirometer by a spirometry over there, where you will see that the FEV1 to FVC ratio is decreased. Then you can do a methacholine challenge test. In a methacholine challenge test, you can see that when you administer methacholine, these patients will have bronchoconstriction. And you have to avoid giving them NSAID. That's what I said in a brief. That's the repeat which I was asked to provide. So that's that. Is everyone clear about this asthma? Very easy to understand. We're not making the patient sicker. We are trying to induce a bronchoconstriction to see how long it lasts to diagnose asthma. Okay, it's not fatal. It's reversible. Reversible bronchoconstriction. Okay. Okay. What to give them except of NSAID? You can give them paracetamols. You can give them you can give them opioids. Okay, but you have to you have to be careful of opioids because they can cause respiratory depression. So you have to give them opioids in a controlled amount. Then you can also give them basically paracetamols, and then what else? You cannot give them NSAID, so you can give them selective COX-2 inhibitors. Also, they are also a little bit dangerous. So that's that. And if nothing works, if the patients have severe pain, then you can give local anesthesia. So that's that. Okay. Does that answer your question? Okay. Why decrease in ratio of inspiratory to expiratory? Because we expect expiration to be longer? Yes, because expiration is longer, because expiration is harder to do. Okay. This is not high yield. Please don't let this confuse you. Just don't forget FEV1 to FVC ratio, that it's decreased over here, and you should be good. Okay. Are we clear about this? Okay. Did we see X-rays of emphysema? X-rays of emphysema. Okay. It's more or less the same thing. It's a COPD X-ray and an emphysema X-ray is more or less the same thing. Okay. Are we clear about this? Area says methacholine challenge the gold standard for diagnosis of asthma or clinical finding. Uh, to be honest, methacholine is not a gold standard. We do X-rays, we do clinical findings, and then if we really want to confirm them, then we can do spirometry. So, and if the patient does not have a history of smoking and the patients are allergic, so we can do a spirometry and that will affect our diagnosis, and then we can understand that the patient has asthma. Okay, next one. Can we move on to bronchiectasis? Okay, bronchiectasis. Bronchiectasis is basically, this is a chronic necrotizing infection. What happens is that in these patients, you have destructions of the cartilages you have the destructions of the cartilage, and then you have destructions of the surrounding structures because you have a long-term infection, for example, chronic necrotizing infection, which can cause a permanent dilatation of the airway. So right now, instead of the alveoli being destructed, you have destructions of the bronchioles, and then the terminal bronchioles and the bronchi, and all of those structures which were held together by the cartilages, there were destructions of those structures, and that is due to long-standing infection, that is chronic necrotizing infection. Okay, so what you find over here is very high yield. The findings of bronchiectasis, I want to talk about them. The bronchiectasis, patients of bronchiectasis, they will have, first of all, they will have purulent sputum, meaning that their sputum will have a very bad smell because they will have pus from the long-term infection. The pus will be there in the sputum, so they will have purulent, bad-smelling sputum. Another one that they will have is, since there's an active infection, they will eat away the small blood vessels, and when the patient coughs, there will be blood with sputum. So that these patients will have hemoptysis. And due to chronic hypoxia, these patients, what they will have is they will have digital clubbing. Okay. Are we all aware of what digital clubbing is? Okay, it's not as if that like they were clubbing, where we're clubbing through the social media or having fun via Facebook and Instagram. That's what they do nowadays, right? During the pandemic. So it's not that. Digital clubbing means drumstick appearance of the fingers of the digits. Okay, digital clubbing. It's not that people of bronchiectasis or patients of bronchiectasis, they go to social media on Facebook and Instagram, and then they attend clubbings and they dance around in their rooms. That's not what's happening over here. Okay, they have drumstick appearance of their fingers, and that is known as digital clubbing. Are we all aware of what digital clubbing is? Have we seen patients of digital clubbing? Very good. Okay, so that's that. Okay. Next one is, what are the causes of bronchiectasis? The causes of bronchiectasis are very easy to understand. First of all, the number one cause, once again, is our friend cigarettes. Okay. Number one, smoking. Okay. If you smoke, this will lead to mucus formation. And when you have mucus formation, you can have mucus plug formation, which will block. And if there's a block, then there's accumulation of mucus. And when there's accumulation of mucus, there's infection. When there's infection, you have destructions of the cartilage. Then you have full-blown bronchiectasis. Next one is primary ciliary dyskinesia or cardiogenic syndrome, meaning that the cilia are not motile, the cilia are not moving. The same mechanism goes for this one. That is when the cilia's don't move, the mucus stay where they are, mucus plugging, obstruction, building behind the obstruction. There's more mucus, then there's infection, and with infection you have destructions of the cartilage, and then you have bronchiectasis. Next one is cystic fibrosis. Cystic fibrosis is a chloride ion channel defect where you have thick mucus, excessively thick mucus. Excessive thick mucus is harder to let go. As a result, there's mucostasis. With mucostasis, what you have is you have the mucus building up, once again, infection and bronchiectasis. Okay, and then another one is APA. APA stands for allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis, meaning that if there's an aspergillus infection of the lung, then they can also result in the formation of mucus and mucostasis, infections of the mucus, and destructions of cartilage and bronchiectasis as a whole. Okay, are we clear about this? Okay. Have we understood the obstructive diseases? CF stands for cystic fibrosis. Oh, clinical features. My apologies. Clinical features. I told you about the clinical features. It's purulent sputum, hemoptysis, digital clubbing. Those are the clinical features. Okay. Are we clear? Allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. It's over here. Okay. Are we clear? Okay. All right. Do you guys want to take a 5-minute break before we move on to restrictive lung diseases? Okay. Before you guys go, let me discuss the diagrams before you guys leave. Okay. So we already discussed about this. This is mucus plugging. This is Cushman spiral. This is Charcot-Leyden crystals. We talked about this. What is A? A, what is A? Does anyone know what A is? Okay. A is basically, this is the appearance of the lungs, which this is the century assigner of appearance of the lung, meaning that this is the carbonated portions of the lung and smoking, as you can see over here. Okay, not very high yield. This is not a very high yield one, but this is high yield. This is the CT scan of emphysema. As you can see that there is formatations of these type of destructions of the terminal septa and dilatations of the alveoli, the alveolar dilatations that you can see over here. This is emphysema. Okay, this is century assigner emphysema over here. Okay, and from over here you have this one over here. Okay, this is your another type of accumulation of this is this one over here. That is, you have the air spaces which are enlarged and decreased DLCO from the alveolar walls, which are shown by the arrow in C, meaning that the diffusion capacity have decreased because there's destruction, right? So there's narrowing of the layers. That's what it means. This is not high yield either. This is high yield. This is high yield. This is high yield. This is not high yield. And then this one over here. This is what is this one is, okay. This is the appearance of the lungs. This is the appearance of the lung. Can anyone tell me what this is, what this looks like? Can anyone tell me what this looks like? Anyone? Exactly. Look at the chest. We talked about this before. Okay. This is the barrel-shaped chest. Increase AP diameter. Okay. Are we clear about this? Okay. Before we start the restrictive lung diseases, first of all, answer me this question. Are you guys understanding the respiratory pathology properly? It's a bit difficult, but it's not very difficult when you questions. Okay. Are the lectures helpful, or are they confusing you? Could you please break more down? Okay, I will try to break down more. I will try to break down more. But the thing is, if I try to break down and go to the, can you guys hear my voice? Is the voice clear? No. No. Okay, how about we take a break back and we talk about the restrictive lung diseases, and I'll try to be more slower and take it at us. How's the pace of the lecture? Is the pace of the lecture okay? Let me get some feedbacks, please. Let me feedbacks. Okay, to be honest, I'm going at a slower pace because the students asked me to go at a lower pace. That's one. Next one is, are we received some feedbacks from a couple of students last week about the associations of first aid. Are we using first aid like how you guys want the first aid to be used? Okay. Okay, very well. Okay, very good. Okay, we're always open to feedback. So if there's anything that you would like to change about the list, please let us know and we will take that into very serious consideration. Okay. Having said that, let's take that 5 to 10 minute break and let's come back and start with the restrictive lung diseases because I do not want you guys to get mixed up and confused with obstructive and restrictive disease. So let's come and do that. So 5 minutes on the clock, 5 to 10 minutes. Let's come back at 12:20. Okay, is everyone back from their break? Is everyone back from their break? Are you guys back? Okay, so it's the end of the week today. How do you guys feel about the weekends? Happy? Do you guys have any plans for the weekends or stay home and, I don't know, do U World or something? Okay. Okay, good, very good. Okay, so can we begin with the restrictive lung diseases? Okay. All right, so let's begin with the restrictive lung disease. Okay. Okay, let's begin with the restrictive diseases. Restrictive lung disease causes restriction of lung expansion, meaning that lungs cannot expand properly. Over here, we have already discussed about the fact how the FVC and TLC will be decreased, and the graph would be, if this is the normal graph, then obstructive disease is over here, restrictive disease is over here. That's that. This shows that TLC is decreased, FVC is decreased, okay, residual volume is also decreased. FEV1 to FVC ratio is either normal or increased, okay? The patients will have short and shallow breath. Now, there are two causes basically of decreased lung expansion. Either you have a problem with your breathing, or either there's a problem with the lungs. So either one of two could be the issue. Number one issue that you can have is you can have poor breathing mechanics, meaning that you have, there's nothing wrong with your lungs, but what you have is you have a problem with the breathing mechanism, meaning that either you can have poor muscular effort in cases of myasthenia, Guillain-Barré syndrome, or polio. Okay, we know that these are neuromuscular junction more like disorders, and over there, either you're not stimulating your diaphragm enough or your respiratory muscles enough to expand properly, so that is causing the restrictive disease. Or you can have another problem, that is there could be so much obesity that the lungs do not have enough space to expand. So morbid obesity is number one. Another one is scoliosis. Scoliosis is abnormal curvature of the spine. So over there you do not have a lot. So this, for example, this is a patient with scoliosis, and this is the lungs. The lungs cannot expand because there's not enough space over here. So that's that. Very easy to understand. And these are the extrapulmonary causes, meaning that it's outside of the lungs. There's nothing wrong with the lungs. There's nothing wrong with the lungs, but there is something wrong with outside of the lungs over here. And then there is normal DLCO, meaning that the diffusion is normal and the gradient is also normal. The AA gradient is also normal over here. So that's that. Okay. Okay. Next one is interstitial lung diseases, meaning the pulmonary causes of lung restriction. Number one is pneumoconiosis. Okay, do we have everyone who understands what pneumoconiosis is? You have a question? You took the 10 eggs. Okay, 10 eggs at 12. Di the diaphragm one. I ate 10 eggs at 12. That's right. No, I did not have the 10 eggs. Okay. Interstitial lung disease. We're talking about pneumoconiosis. Do you guys know what pneumoconiosis is? Do you guys know what pneumoconiosis is? Pneumoconiosis, you do not remember what pneumoconiosis is? Pneumoconiosis is occupational lung disease. Pneumoconiosis is occupational lung diseases. Okay, occupational lung disease are, for example, you have a coal worker who can inhale coal. What happens over here is that if you have a coal worker, let's say that this is the lungs of the coal worker, right? If you inhale coal, coals are black. If you inhale coal, that coal can go and stay in the lungs, and it will deposit in the lungs, and in the lungs there will be formation of fibrosis, then sort of a granuloma like formation, and this coal can induce fibrosis, and this fibrosis can cause restrictive lung disease. Okay, these are the pneumoconiosis. How many types of pneumoconiosis do we have? We have coal worker's lung, for example. Then we have silicosis, and then we have asbestosis. Asbestosis, silicosis, and asbestosis. That. Next one is we can have a disease called sarcoidosis. Do we remember what sarcoidosis is? You guys know what sarcoidosis is? Sarcoidosis. Okay. Non-caseating granuloma formation with bilateral hilar lymphadenopathy. That is sarcoidosis, meaning there's a non-caseating granuloma and there's bilateral hilar lymphadenopathy. And the thing is with sarcoidosis is also responsible for increasing calcium, and because the granulomas, they have one alpha hydroxylase enzyme, they activate vitamin D, and this results in increased calcium absorption from the gut. That's that. And also they have another enzyme, that is angiotensin converting enzyme, that is ACE. So more amount of angiotensin is being formed over here. Okay, next one is idiopathic pulmonary fibrosis. That is we do not know the cause of this. That's why the name is idiopathic. But what happens is you have repeated lung injury and repeated fibrosis, for which you have increased deposition of collagen. So these patients, they have a honeycombed appearance of the lung. You know, like how honeycomb is basically. Have you guys ever seen a honeycomb? You guys know what a honeycomb is? Honeycomb, where we extract the honey from the honeycomb appearance of the lung. So this is exactly how the lung appears over here, the honeycombed appearance. In idiopathic pulmonary fibrosis, the cause is repeated injury and repeated fibrosis. As a result, you have collagen depositions over here. Okay, so that's that. Next one is an next one is an arterial disease, that is Wegener's granulomatosis. Wegener's granulomatosis. Wegener's granulomatosis. Which ANCA is positive? A C ANCA or P ANCA? Answers, please. C ANCA positive. We all know what Wegener's is. Okay, Wegener's, nose, lungs, kidney, right? Like a C over here. Okay. Next one. Next one is pulmonary Langerhans histiocytosis. Do you guys remember we talked about pulmonary Langerhans histiocytosis in hematology? Anyone? Pulmonary Langerhans histiocytosis. We talked about this in hematology, and over there you have formations of eosinophilic granuloma. If you guys have not heard of pulmonary Langerhans histiocytosis, this is nothing basically but eosinophilic granulomas over here. Eosinophilic granulomas. That's that. Next one is hypersensitivity pneumonitis, and then drug toxicity. For example, bleomycin, busulfan, amiodarone, and methotrexate. Over here, amiodarone is very high yield because it's well known for causing pulmonary fibrosis. Amiodarone, which is an anti-arrhythmic drug. Anti-arrhythmic drug. Okay, amiodarone. That's that. Okay, next one. Next one is hypersensitivity pneumonitis. What is hypersensitivity pneumonitis? So what are the causes of restrictive lung disease? What are the causes of restrictive lung disease? First of all, let me say it once and then you guys can see it again. First of all, you have poor lung movement and lung disorders. Poor lung movement, you have, first of all, you have diseases such as polio, myasthenia, Guillain-Barré, then you have scoliosis and obesity. Am I correct? Yes or no? Am I correct? Am I correct? No? Okay. Then you have pulmonary disorders. You go over there, you have pneumoconiosis, sarcoidosis, idiopathic pulmonary fibrosis, Wegener's granulomatosis, then pulmonary Langerhans histiocytosis, hypersensitivity pneumonitis, and drugs. Are we clear? Is anyone confident to mention the names? Is anyone confident to mention the names? Anyone? So that we can have a revision of all the causes of pulmonary lung friction restrictive disorders. Okay, let's hear it. Okay, let's hear it. Well, what are the causes of restrictive lung diseases? Okay, everyone can join. Just write in the chat box, no problem. Write in the chat box. What are the causes of poor breathing mechanics? Fast answers, please. We don't have a lot of time. It's already. What are the causes of poor breathing mechanics? Poor breathing mechanics. Very good. Okay, what are the causes of pulmonary causes of lung disease? What are the pulmonary causes of lung disease? Sarcoidosis, idiopathic pulmonary fibrosis, pneumoconiosis, then what? Drugs, busulfan, butyron, right? Okay. Okay, hypersensitivity matters. Okay, next one. Now we will learn about sarcoidosis. Okay, we will learn about sarcoidosis. Sarcoidosis, and then we have the pneumoconiosis today. Okay, mesothelioma. Okay, all right. Sarcoidosis. Okay, let's talk about sarcoidosis. What is sarcoidosis? Sarcoidosis is characterized by immune-mediated, widespread, non-caseating granulomas. Okay, this is an immune-mediated, widespread. The granulomas are non-caseating. Over here, you have two findings. If you do a bronchoalveolar lavage, okay, if you do, wait, let me take another page. Okay, if you do a bronchoalveolar lavage, one second, okay, if you do a bronchoalveolar lavage, you find two things. One is increased ACE, another one is increased CD4 to CD8 ratio. CD4 to CD8 ratio. Can you guys please write this down over here so that you guys can easily review this? We'll write this down over here. Bronchoalveolar lavage, the two findings over here. Okay, ACE and CD4. This is very high yield. For okay, you can't forget this. First of all, sarcoidosis as a whole is very high yield. Okay, this is very common over here, so you have to understand this. This is basically nothing but a immune-mediated non-caseating granuloma. This is more common in African American females, and then if it's often asymptomatic except for enlarged lymph nodes. The lymph nodes over here are enlarged. As you can see that you have bilateral hilar lymphadenopathy. That is this potato-shaped lymphadenopathy over here. This is bilateral hilar lymphadenopathy. Chest X-ray will show bilateral adenopathy like the one which I just made over here, and coarse reticular opacities. As you can see, there's opacity, that is reticular opacity over here. Okay. Okay. And then what you will get is the CT scan will demonstrate that there's extensive hilar and mediastinal adenopathy over here. If you do a CT scan like this one, then you will see extensive mediastinal and hilar adenopathy. That's that. Okay. Okay, this is sarcoidosis. Okay, now the thing is, sarcoidosis, how do you get hypercalcemia from sarcoidosis? This is something which I want to mention. The granulomas, that is this one over here, these type of granulomas, this is a non-caseating granuloma, meaning that there is no central necrosis. There is just a formation of a granuloma over here, and it is surrounded by epithelioid cells, large giant cells. These are non-caseating granuloma. There is no caseation. These granulomas, they have a high yield enzyme, that is 1-alpha hydroxylase. 1-alpha hydroxylase is also present in proximal convoluted tubule, which is responsible for activating the vitamin D for increasing the absorption of calcium from the gut. And this enzyme, they also do the same thing. They activate the vitamin D. So the vitamin D is activated, which can go and stimulate calcium absorption from the gut. As a result, these patients have hypercalcemia due to 1-alpha hydroxylation mediation in the macrophage. They have hypercalcemia. Now, the associated functions of sarcoidosis. What are the associations of sarcoidosis? The associations of sarcoidosis are in a patient of sarcoidosis, you can expect Bell's palsy. Okay, which cranial nerve is affected in Bell's palsy? Which cranial nerve is affected in Bell's palsy? Everyone? Very good. Understand Bell's palsy. Then you have uveitis, which is a systemic disorder. Uveitis. Okay, uveitis. Always remember that the uvea, when there's inflammation of the uveal tract, then this shows that there is a systemic inflammation. For example, sarcoidosis or rheumatoid arthritis, they will have uveitis. Okay. Then you have granulomas. Granuloma, which are non-caseating granulomas. And these granulomas, they are non-caseating granulomas, which will contain this structure over here, which will contain microscopic Schumann bodies and asteroid bodies. These granulomas, as you cannot see the Schumann and the asteroid bodies. This is not very high yield, but if they do for some reason, please try to remember. Even if you can't remember, it's not a big deal. So that's that. Okay. Next one is lupus pernio. Next one is lupus pernio. What is lupus pernio? Let me show you a picture. Lupus pernio is the skin function. Lupus pernio is the purple color skin, which you can see in a patient with sarcoidosis. This skin resembles as a patient of lupus, but it's not really lupus. It's actually sarcoidosis. So this is known as lupus pernio. This purple color skin appearance, lupus pernio. Okay, so lupus pernio. Okay, then next one is pulmonary fibrosis or interstitial fibrosis. Okay, interstitial fibrosis. Then what you get is you get erythema nodosum. Erythema nodosum. What is erythema nodosum? These are these type of skin findings over here, erythema nodosum. Okay. Did we talk about erythema nodosum when we discussed dermatology? When we discussed skin and dermatology? Yes? Okay, good. So erythema nodosum. Okay. Then what else? Then over here, these patients, they can also get arthropathy, rheumatoid-like arthropathy. Okay, rheumatoid-like arthropathy, meaning joint pain. Try to realize how each and every word over here I used is the first words of this word, that is uglier. U for uveitis, G for granuloma, L for lupus pernio, I for interstitial fibrosis, E for erythema nodosum, R for rheumatoid-like arthropathy. Okay, these are all the associated findings. And there's another word, anomaly, this is B for Bell's palsy. Okay, are we clear about this? Are we clear about this? Yes, in ulcerative colitis too. Erythema nodosum. Okay, okay. Okay, so sarcoidosis, let me do a fast revision of sarcoidosis. First of all, sarcoidosis, what are the findings you will get in a bronchoalveolar lavage? What are the findings you will get in a bronchoalveolar lavage? Increased ACE and CD4 to D ratio is high. Good. Okay, what do you expect to find in a patient of sarcoidosis when you do a chest X-ray? Please, chest X-ray. Lymphadenopathy and okay. What do you expect to find a patient when you do what do you expect to find in a patient when you do a CT scan of sarcoidosis? CT scan of sarcoidosis, what do you find? Fast answers, please. Okay. Then, do you expect to find a patient of sarcoidosis with hyperglycemia? How? How do you expect to find that? Okay. Are we clear about sarcoidosis? Okay. How do you feel? Do we feel confident regarding sarcoidosis? Okay, very good. Okay, next one is inhalation injury. Do you guys? Okay, I'm not sure why a lot of students are already leaving. It's 12:40 as of right now. Do you want to stop the lecture over here and start with you roll? You guys want to start with you roll? I feel like you guys are not into lecture today as much. Am I correct? Okay. Okay. Let's finish the page. Okay, no problem. Let's finish the last page and then we can move on to URL. We already have not a lot of students who are performing the lecture because a lot of students said they will not be coming today because of the fact that it's Friday. So maybe that's that. But okay, so let's finish the last page over here. Let's see what they say. Okay, so the last page, the last thing is inhalational injury and the sequelae and the sequence of inhalational injury. First of all, due to complication of inhalation of noxious stimuli, for example, smoke, this can be caused by heat, right? Particulates which are less than 1 micrometer in diameter, or irritants, for example, ammonia over here. Okay, then what you get is you get chemical tracheobronchitis, edema, and pneumonia. You can also get ARDS. This is not very high yield. Many patients will present secondary to burns, carbon monoxide inhalation, cyanide poisoning, or arsenic poisoning. Do you guys realize there's not a lot of high yield information you need from over here, except the fact that there's only one thing. Okay, there's only one single thing which you need. That is this one. That is, if there is a patient of inhalational injury, what do you expect to find? You expect to find singed nasal hairs or soot in the oropharynx in common in exam. If you find soot, SOOT, soot in oropharyngeal exam, then this can mean that these patients have inhalational injury. And if you do a bronchoscopy, you can see edema and congestion and soot depositions as over here. Okay. And then what you can get is, this is acute, so it's all red, and B is, I mean, this is acute, and this is B, which is basically after the resolution. So there is fibrosis. So that's that. Okay. But the only thing that is important over here is if you find soot in oropharyngeal examination, this means that these patients have inhalational injury. Okay. Are we clear? Are we clear about this? What is the only high thing you need from this one? The presence of soot. If there is soot, you will have only one question in your role from inhalational injury, and that is soot or singed hair. That's that. Okay. Okay. Can we do the UL questions right now? Okay. Okay. All right. Let's start the UL question. We can start with this from tomorrow. I mean, from next week. From next week, what we will be doing is we will be starting with our basic science topics. So we'll be starting with genetics and biochemistry, and we would be using physio with this alongside hand by hand, and we will try to break it down. How hard do you guys find genetics and biochemistry? Is it very important and very hard? Yes or no? Well, if you do the lectures with complete attention, it will be extremely easy. I will do exactly what you need to study, how you should study them, and how you should review them to get that mark which you have not been getting for genetics and biochemistry. Because what happens with genetics and biochemistry is, there's one thing which I want to make clear before I start the lectures on genetics and biochemistry is, you cannot expect to understand 100% of genetics and biochemistry, because that requires a lot of in-depth knowledge. Okay, but if we want to do good in the USMLE Step 1 exam, we have to make sure that we understand exactly what's needed and what is the type of questions that are being asked. Because if you can see that in genetics and biochemistry, the people who make the questions, the doctors who are responsible for making the question, they know that genetics and biochemistry is very difficult. If they wanted, they could have asked you the most difficult genetic questions. Was that not a possibility? that that they can ask you, because we have geneticists over here who can ask you questions which are so difficult that you will have no idea what the answer is or what the question is even asking you. So they keep on asking you guys the same question over and over and over again. So if you guys can understand the pattern, which I will tell you exactly what it is, then you guys can realize that genetics and biochemistry is actually pretty easy. Okay, so that's what we're going to do. So do not worry about anything. Make sure that you guys don't miss out on this part of the lectures. Okay. Make sure that if you guys have friends, please let them know. If they have to join the lectures, then this is the best time to join the lectures, because we will be starting first aid exactly from the first, that is from the first chapters. Okay. So if they want to join, now is the best time, to join. And another thing is we will be using physio hand in hand. Okay, we would be using physio hand in hand, and we would be making sure that we don't forget any of the high yield ones. Okay, are we clear about this? Are we clear about this? Okay. Okay. Okay, Dr. Hassan, don't worry. Please send us an email and we will get back to you. Okay. Does anyone have any questions before we begin the UWorld questions? Okay. Are we all excited and ready for next week to start the basic science, biochemistry, genetics with the physio? Okay. When will we start biochemistry? Next week. I just said it. Next week. We'll start with genetics and biochemistry. Okay. How do you guys feel about almost finishing the organ systems? Very close. You guys are so close to finishing the organ systems. We have discussed more or less everything. Not a lot of students. Who are the students over here who has been doing the lectures with us from the beginning? Okay. Okay. Who else? Okay. How do you guys feel? How do you guys feel? Okay. Okay. You guys should feel more confident. Okay. Very good. So let's begin with the UWorld questions. You missed cardio and endocrine. Don't worry. We will do cardio and endocrine once again. Okay. We will do cardio and endocrine once again. Okay. So let's begin with the UWorld notes. Okay. Okay. Before we begin the UWorld notes, do you guys want to take a 5-minute break so that I can prepare the notes? Yes or no? Okay. Okay. Notes and questions, both. You're welcome. Okay, is everyone back from their break? Okay. How long has it been? Has it been 5 minutes? No, it's been only 2 minutes. Okay. So don't worry, we'll wait for 3 more minutes. We're over here. Okay. Is everyone back from their break? Can you guys hear my voice? Okay. You guys are at liberty to unmute yourself and answer these questions. Is everyone ready to start with the UL notes?
Yes.
Okay. Is everyone ready? Should we
Yes,
begin?
doctor.
Okay, good, very good. Let's begin with the UL notes. Okay. Um, okay, first of all, before we begin with
Can you
before-
share the screen just before we
Oh, right, my apologies, sorry. Okay, so basically what's happening is before we begin with the URL notes, some rules and regulation, basically, to make sure that if everyone can hear what we are discussing about, if you have a background noise, please refrain from unmuting yourself for being considerate of the rest of the students. If you want to ask any questions, please make sure that you let us know. And if you are ready about an answer, please tell me you're ready and then only answer after that. And that's that. Okay, so with that being said, let's begin. If the first question is, or the first notes is, okay, okay, 1 second. Okay, if we have T cells with cerebriform nuclei.
Okay, ready.
Ready.
Very good. So it's a pretty difficult question. Not a lot of students have answered this. Okay, so all the students who said ready, is there anyone else who wants to participate?
Ready.
Okay, very good. So what is the answer for everyone?
Caesary syndrome.
Or mycosis fungoides.
Mycosis fungoides.
The next.
Earlier form.
Okay. Mycosis fungoides or Sézary syndrome. Very good. Okay, next one. Next one is if we have thymic, do we have thymus?
Yeah.
Yeah.
Yes, but it's atrophied already now.
It's atrophied.
Thymus involution. What is the process of involution of thymus? Is it necrosis, apoptosis, atrophy?
Atrophy.
Nope.
Hypoplasia.
Apoptosis.
Okay.
Fusion of lipid instead.
Do you guys realize how easy this question was, but how difficult it was for everyone to answer the right way? We all know that thymus involution happens, but a handful of us are aware that it's apoptosis. So Usmle will try to test your very basic science, your very basic knowledge by asking you these type of hidden questions. Okay, next one. Okay, Bernard Solier syndrome. Bernard Solier syndrome. Does it present with small or large?
Markers.
Large.
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 Large. Platelets.
Okay. Okay. Next. Oh, okay. Okay. Next time. Okay. Just please say ready before you guys answer, so that everyone can get a chance. Next one is. Okay. Next one is. This one is not a question. Have you guys heard of lipodystrophy or fat accumulation?
Yeah.
Yes.
Okay. Which type of anti-HIV medication is more associated with
Ready.
lipodystrophy?
Ready.
Ready.
Let's give the student who said ready first, maybe a chance. Okay. So
Protease inhibitor, like second.
what is the answer?
Protease inhibitor.
Okay, I think I heard protease inhibitors. And
Yes.
that right? Okay, very good. Good job, guys. Thank you so much. Okay. Okay. Can you guys name this microorganism? It's a gram-negative coccobacilli with. Have you guys heard of a safety pin?
That's ready.
Okay, very good. Okay, okay. To the. Is anyone else ready? You guys need more time. Okay, so let's go with the first student who said I'm ready. Okay, what is your answer, please? First student who said ready, what is your answer? Can you guys hear my voice?
Yes.
Yes.
Okay. What is your answer? Anyone?
I'm not sure, but Listerine?
No. Good. Good try though.
Yersin.
Okay. Safety pin appearance. Okay. Gram-negative coccobacilli, they have a safety pin appearance. Okay. Be careful of this one. This is a hard question. Okay. Safety pin appearance. Yersinia pestis. What does Yersinia pestis? What does it cause? Does anyone know?
Black.
Black.
Plague. Very good. Okay. Next one is how will you treat a patient with porphyria cutanea tarda? The number one choice of drug.
Glucose or dextrose.
Ready.
Okay. What is the answer?
Ready.
Okay. The first student who said ready, what is your answer?
Glucose or
Glucose.
dextrose.
Okay. If you have to give a medical drug, what will you give?
Ready. Hydroxychloroquine.
Okay. Very good.
Hmm.
Very good. Okay. In a patient with combined HIV and HBV, which anti-HIV medication is the choice of drug? A very hard question from Amboss. Combined HIV and HBV together, what will you give? Okay.
Tenofovir.
Okay. What is the drug? Sofosbuvir used in?
HIV.
Nope.
Hepatitis.
HCV. Okay. I'm moving a bit fast because I want to finish this. Okay. Next one. Next one is one second. Genital ulcer. Which is painful and at the same site of a previously healed ulcer. So reinfection. by the same organism right now. Previously, it was also painful. Then it got healed, and right now it's painful again. What is the organism?
Ready?
Ready.
Okay. Anyone else?
Ready.
Okay. Let me see if there's anyone else in the chat box who wants to give answers. Anyone else in the chat box wants to give answers? Yes, Dr. Dahlia. What is your answer? Herpes simplex. Nope, herpes simplex unfortunately is not the right answer because the vesicle formation. So that's that. Okay, varicella zoster, once again, it's not the right answer because once again, no history of vesicular formation. Anyone else? Anyone else?
The
Which one?
Is it Haemophilus influenza?
Anyone else?
Haemophilus influenza, doctor.
Nope.
So
How
chlamydia.
about Klebsiella? Okay, this is Klebsiella granulomatous. And
Klebsiella.
yeah, unfortunately, this was the only piece of information given in the question in emboss. And previous infection which is healed and then produces another painful infection is common of Klebsiella granulomatous. Next one is okay. Okay. If you have a chest X-ray with chest X-ray positive of opacity with hypercalcemia, what are your differential diagnoses?
Sarcoidosis.
Okay, sarcoidosis is one. Anything else?
Small cell lung carcinoma.
Very good. Okay, all right. Next one is, did we do this one before?
No.
Yes. Okay. Did they give explanation for Klebsiella granulomatous? They gave explanations, but mostly that was because Haemophilus ducrei would okay. What is the lesion of Haemophilus ducrei? What is this called? The lesion of Haemophilus ducrei. What is it called? No, I know, but what is the lesion of Haemophilus ducrei? What
Chancre?
lesion?
Chancroid.
Chancroid. Okay. The thing is, if we have a lesion of all the genital ulcers which were previously painful, if they healed, high possibility they will not appear in the same place again, except Klebsiella granulomatous, which has the possibility of causing reinfection at the same site after fibrosis has happened. It can again accumulate and cause painful ulcer and painful lesion at the same previous lesion. So that's that. That was the only piece of information that was given, and unfortunately, that's that. I hope you guys do not receive these type of questions in the actual exams because these are very hard and very difficult to understand. So, but I'm just sharing all the the difficult questions with you guys, so that even if you guys do, maybe our discussion on this one can help you guys out to think that it could be Klebsiella. That could that.
Dr. Belief, I have question.
Yes.
This obesity chest X-ray with hypercalcemia, sarcoidosis, and small cell or squamous cell carcinoma.
Oh, right. Squamous cell carcinoma. Squamous cell carcinoma. Very good. Because there's ectopic PTRH related peptide, not small cell lung carcinoma. Very good. Okay. Squamous cell carcinoma. Okay. Okay, I got a bit distracted because of these questions over here for the Klebsiella. I was thinking about that. Okay, so my apologies. Squamous cell carcinoma. Okay. Okay, next one. If we do cricothyroidectomy, what are the layers that we have to incise? Incision of which layer?
In
Skin is obvious. Then
Cricothyroid
superficial
membrane.
fascia. Superficial fascia.
okay. So let me answer this question for you so that I don't make a mistake. Okay. This is incision of superficial layer of cervical fascia. Then
Then
deep,
platysma.
no, the deep cervical fascia and transverse cricothyroid membrane. These are the 3 layers for cricothyroidectomy. Am I clear?
Yes.
Yes.
3.
Yes.
Okay. Okay. I think I discussed this before. I'm not sure if you guys can remember this, but I think I did. Oh, okay. This is high yield. Okay, muscle catabolism in cancer. What is the mechanism of cachexia? Okay, mechanism of cachexia. First of all, you have release of cytokines for cancer. That is IL,
Tumor necrosis factor.
right? IL-1, IL-6, and TNF. They induce increases in FKB, which activate UB creatine proteasome pathway, and there is proteasomal degradation of tissues. Okay, this is the mechanism for muscle catabolism in cachexia. Okay. 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 Next one is okay. Last question. Okay. Last question before we move forward. I think I discussed this question before. If we have an aneurysm of posterior cerebral artery,
Yes. Which nerve?
nerve is damaged.
3.
Cranial nerve 3.
Promoter.
Did we do this before? I think I did this before.
Yes.
Yeah.
If we have, okay, I think I did this before. Okay. Okay. Next one is if you have a patient, not the last one, young patient with failure to thrive, hypotonia, HOCM, with normal glucose. I'm not going to write a HOCM, it's just CM, meaning cardiomyopathy. It could be hypertrophic or DCM. Okay, what do you think this patient has?
Glycogen storage disease.
Which one?
Pompeo.
Pompous.
Okay. Did we discuss this?
Yeah.
Not the same was.
Yeah.
Indirect.
Kind of.
From another side.
Okay, Pompei's disease. Okay, so that's it. That's for the UWorld notes. We're not doing a lot because we're almost done with everything. Okay, thank you so much for participating in the UWorld notes discussion. My question to you guys is, okay, first of all, thank you so much for doing the UWorld notes. And my question to you guys is, all these notes over here that we made, each and every line is a question. Okay, like for example, this is one question, this is another question, this is another question. So basically we discussed all these high yield questions. Okay, my first question to you guys is, did you guys find questions in UWorld common to the discussion in UWorld notes? Yes or no? Okay, so they are pretty helpful. So okay, so these notes over here, Do you guys read them, or are you guys just saving them for later? Okay. Please make sure that you read at least one or two of these every day, because I'm telling you guys what would happen is at the end of your study, if you have these notes left, they will be a huge burden. They will be a huge burden. You will not be able to read them and fully utilize these notes. These notes can help you separate from a lower mark to a higher mark. Okay, so please make sure that you guys do these notes. Okay, please read them every day, at least one page every other day. Okay. Okay. So with that being said, we'll begin with the questions. We will do 6 questions today from Kaplan. Okay, 1 second. Okay, just give me 1 second, guys. Can I have a look at the last page? Yes, sure. Okay, just give me 1 second. Okay, we're almost ready. Okay, you're welcome. 1 second. Okay, let's begin with the questions. Okay. So as we all know, USMLE Step 1 is an 8-hour question, 8-hour exam, 7 hours the actual exam, 1 hour is a break. For each and every question, you get 90 seconds. Okay, there are 280 questions per day, and you get 1 hour to solve 40. So one question is 90. Okay. First of all, can you guys see my screen? You guys are at liberty to unmute yourselves. And
Yes.
ask questions. Okay.
Yes.
So let's begin. Okay, so the first question that we will be discussing today is this one over here. That's what we will start with. We will try to see how many we get right today. Okay. Okay. So when we read the last part of the question, okay, so before we discuss, first of all, before you answer, please make sure that if there's any background noise, refrain from unmuting yourself. And if you guys are ready, please tell me you're ready and then provide the answer so that it's fair to everyone who needs some more time to think about the question.
Ready.
Okay, no, wait, I did not start yet. Okay, so we're gonna start right now. 1 second. So this is the question that we're gonna do, 90 seconds. We will read the last line first. That is, the patient's cancer is most likely which of the following. A 50-year-old industrial chemist presents with painless hematuria. On further question, he also describes urinary frequency and urgency. After testing, a diagnosis of bladder cancer is made. Okay. If anyone is ready, please tell me you're ready. We have one question. We have one
Ready.
student.
Ready.
Ready.
Okay, who was the first student who said I'm ready?
Ready.
Me, Dr. Kavasi.
Okay, doctor, what is your question? What is your answer?
I would say E.
Does everyone agree with E?
Yes.
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 Okay, why
Yes.
not?
I am with D.
You're with D?
Yes.
Okay. Who else is with D? Okay, why is D not the right answer?
Because industrial chemists are mostly predisposed for transitional cell carcinoma.
Okay, why?
The chemicals.
Because the chemicals like rubber and others make
Then the
transitional cell
name is nitrosamines. Okay, nitrosamines. That is the industrial chemical, and E is the correct answer. Okay, so very good. D is more common if you're exposed to schistosoma hematocritus. Okay, if you go for swimming in ponds, then D is more common. So unfortunately, it's not the right answer. E is the right answer. E is transitional cell carcinoma. Okay, very good. Okay, so one. Next one. Next one is these symptoms are likely the result of which of the following neoplastic syndromes? A 42-year-old man previously diagnosed with kidney stones complains of gnawing, burning epigastric pain. On questioning, he also notes moderate to severe diarrhea. Underline this, underline this. Measurement of the patient's basal gas output reveals that it is markedly elevated. Okay, easy question. So patient has diarrhea and some symptoms of hypercalcemia. So there are two P's that's already there. Now, what is the correct answer? If you're ready.
Ready.
Okay. Anyone else? Is there anyone else who needs some more time? If you need more time, please tell me you need more time. Okay, I guess not. Okay, so the first student who said I'm ready, who was the student?
Me, maybe.
Okay, what is your answer?
B.
E? E or B?
B like
B
brother,
as ball.
Oh, B.
like
Okay.
brother.
Yeah.
The student with the background noise, please unmute please mute yourself. Okay, thank you so much. B for brother, which is multiple endocrine neoplasia type 1. Does everyone agree with B? Yes or no?
Yes. Yeah.
Everyone? Everyone else? You guys agree with B? Very good. So B is the right answer. Okay, so B is the right answer. Very good. That's that. Multiple endocrine neoplasia, which consists of PPP. P stands for pancreatic neuroendocrine tumor. Over here, the pancreatic neuroendocrine tumor is VIPoma. Okay, and then pituitary adenoma and hyperparathyroidism. So hypercalcemia, and this patient would likely also have bitemporal hemianopia, which they did not mention. So that's that. Okay, very good. 2.
Doctor, from what the epigastric burning pain? Also from
Gastrinoma.
Gastrinoma.
Ah, so he can have both VIPoma and gastrinoma together?
Right, he can have both.
Okay.
Okay, okay, very good. Next one. Next one is this woman should be told that she has an increased risk for developing which of the following diseases? Bladder cancer, endometrial, ovarian, renal, vaginal cell. A 40-year-old woman comes to the physician for a periodic health maintenance examination, has no complaints, but she is concerned about, very easy. Okay, let's see. Okay. Who was the student who said I'm ready?
Jordan.
Okay, Dr. Jordan, what is your right answer, please?
I think it's E.
Vaginal clear cell adenocarcinoma. Does everyone agree with E?
Yes.
This one, everyone agrees with E. Okay, why? Because the patient was exposed to ethanol estradiol, which is diethylstilbestrol. Okay, very easy. Okay, very easy. 3 questions, right? Okay, this is a big question. Okay. Okay. Which of the following is the most likely cause for the newborn's constipation? Okay, 3-day-old, full-term male has not passed meconium. History reveals that the infant was born to a 24-year-old primate after an uneventful pregnancy. Okay, the delivery was cesarean section due to fetal-maternal disproportion. Okay, the baby weighed 3.2, Apgar, and had normal Apgar scores. Okay,
Ready.
Started on formula feeding. Very good. Okay, please just wait a minute. Which was tolerated without incidents of vomiting. He passed urine shortly after birth, but passage of meconium has not been observed. On examination, he appears in no distress and feeds vigorously, no dysmorphic features. Liver and spleen are not, and the bowel sounds are Very long question. Okay. Examination of the perineum reveals normal male genital and normally placed anal atresia. Which of the following is the most likely cause of the patient's constipation? Okay. So we have one student who is ready. That is very good. Is anyone else ready, or do you guys need more time?
Ready.
Ready.
Okay. So the first student who said I'm ready is that student.
It was me, Dr.
Okay.
Kavasi.
Okay. What is your answer?
I would say C.
Okay. Does everyone agree with C?
Yes.
Yes. Yes.
Okay. Why not? Okay. Why C? Dr. Karbasi, why? Why?
Because I remember there was like a similar question in UWorld, and
Mhm.
then it was like, and they explained on Hirschsprung disease that I think that I think in the begin at the sigmoid, like in the descending column to the sigmoid, that there will be a problem of defecation, but I forgot like perfectly the explanation.
No
Why,
problem.
but
Okay, no problem. So you chose C. That's okay. Dr. Khatun, since you need more time, what is your answer, Dr. Khatun? Since you needed more time, what is your answer? What do you think the answer is? What do you think the answer is? Dr. Sabira Khatun, what do you think since you needed more time? Okay, you answer also C. Does everyone agree with C?
But doctor, I have a question.
Okay.
In the last four sentences, examination of the perineum reveals normal male genitalia and a normally placed anal atresia.
Mm-hmm.
He is already diagnosing the patient normally placed anal atresia.
Yeah, I think what this is this is a mistake. Okay.
Yeah,
This should not be
anal canal or something.
Yeah, the normally placed anal canal. That's what this should. I think there's some sort of a mistake over here. Okay, so that's that. So having said that, does everyone agree with C?
Yes.
Yeah.
So C is actually the right answer. So very good. Congratulations. C is the right answer.
Doctor, why not D? Why not P? Like brother?
Duodenal
Because
atresia. Duodenal
no vomiting. Yeah.
Okay. So duodenal atresia, the patients would have vomiting.
Yes.
Okay. In duodenal atresia or pyloric stenosis, they will have vomiting. In Meckel's verticulum, they will have rectal bleeding. So those are not there. Okay. In anal atresia, they will have no amount of passage of any type of meconium at all. Okay. But even in anal atresia can also be presented in these patients, but what happens is that Hirschsprung disease, it can be detected during the examination of the newborn, where an ectopic or absence of anal opening can be detected. Do you understand what I mean? Hirschsprung disease is more easily detected. Okay.
Mm-hmm.
He is ruling it out
Yes, we're actually
by
ruling
saying it is normal. Yeah.
yes.
so you would say if there would be vomiting, because without any incidence of vomiting, but if there would be vomiting, then we have to say duodenal atresia, right?
If the patient presented with vomiting, then we would have to consider duodenal atresia and pyloric stenosis. Yes.
Okay.
And in duodenal atresia, there is meconium or no? In the first time, no.
There is
I
some
think
amount
it
of
will be, yeah.
some amount of meconium passing. But the thing is, duodenal atresia, there will be some amount of meconium, but not a lot.
Okay.
Okay. And since it says that there is a normally placed anal canal, anal atresia is not the right answer.
In Michael Dictor,
Because the reticulum will have rectal bleeding. Rectal bleeding. Okay.
yes.
Okay. Okay. Next one. What is the most likely histological appearance of the biopsy? Okay, if we do a biopsy of these patients, a 65-year-old man with a history of smoking and alcohol abuse complains of poor appetite and difficulty swallowing to both liquids and foods. He has lost 20 pounds and vomits blood. A mass is detected. Okay, if anyone is ready, please tell me you're ready.
Ready.
Okay, very easy question, as a matter of
Ready.
fact. Okay. I'm pretty sure you guys think C is the right answer, right?
Yeah.
Okay.
Yeah.
It's not the right answer. Okay. Okay. So try again. Okay, my apologies. No, C is the right answer. Okay, C
Oh,
is the yes.
Really? Yeah.
It is squamous cell carcinoma.
Yes.
a little bit depressed when you say it.
Yeah. No. I thought it was something else too. I thought I was looking for cellular bridges because
Yes, I also looked, but wasn't.
I was looking for keratin pearls and intercellular bridges, but I realized that it's not there as an option. So usually what happens is that in squamous cell carcinoma, you have keratin pearls, intercellular bridges. Yes, also you have zones of transition. Okay. So, okay, my apologies. So this is a giveaway. I give this mark to you. Okay. So how many questions did you guys get right?
Oh,
1,
4, right?
4, 5. Okay, 5 out of 6. Very good job. Let's see if you guys can get right the last question. I was looking for keratin pearls and intercellular bridges, but it's not there. Okay, so squamous cell morphology is the next right answer. Very good. And you guys understand, right, that this is squamous cell carcinoma because of smoking and alcohol. So that's that. Okay. Next one. A 7-year-old boy with chickenpox is given aspirin to reduce his fever. He develops vomiting, mental status change. Okay, this is also very easy, and eventually falls into a coma. Okay, before you guys answer this question, the student who will answer will name the condition first, and then we'll answer the question. Okay.
Mm, okay.
Okay, so if anyone is ready, let me know. I'll give you guys 30 seconds.
Ready.
Ready.
Okay. Anyone else? Let me see the chat box. Anyone else on the chat box who wants to answer? Anyone? Dr. Okay. So let's give Dr. Uday a chance. 1 second. Let's read the question again for Dr. Naoud. 7-year-old boy with chickenpox is given aspirin to reduce his fever. He develops vomiting and mental status changes. Which of the following would you expect to see on a biopsy? These are the ones. Dr. Uday, okay, would you be kind enough to let us know? It's Reese syndrome. Very good. And what is your answer? Dr. Uday, write it in the chat box, no problem. Okay, so you chose hepatic necrosis, which is D. Okay, so Dr. Uday chose D. Does everyone agree with D? Everyone, do you guys agree with D?
Yes.
What do you expect to find in a patient with Reese syndrome? Do you expect to find hepatic necrosis or what?
We find fatty liver, I guess.
Fatty liver
Yes,
initially. Yeah.
fatty changes, I think.
We
Okay.
find fatty chains.
Okay, so unfortunately, D is not the right answer, but a very good try because you mentioned that it's Reese syndrome, which is the correct answer. It's Reese syndrome, but in Reese syndrome, we see fatty changes first. We see fatty changes first. So the answer is fatty changes. Okay, so the answer is fatty changes, and and there is actually very little hepatic necrosis in Reese syndrome. So that's that. And what happens in Reese syndrome is you have disruptions of the mitochondria, right? So
Yes.
that's another thing over here. Okay. And every other thing, such as the Mallory bodies, they're found in alcoholic hepatitis. Then you have hemosiderin deposits, which are found in hemochromatosis, right? And then diffuse fibrosis with areas of regeneration is seen in hepatic cirrhosis. In hepatic cirrhosis. Okay, so that is your answer. Okay, so with that being said, thank you so much. I will unmute you guys right now. And thank you so much for participating and letting us know all the right answers. You guys did very well. I would give you guys a 6 out of 6. Okay, so this is a very good way to end the week. Okay, so you guys have a long way of doing really well in your exam. I mean, in your questions. And okay, so how do you guys feel more how do you guys feel? Do you guys feel more confident or less confident? More confident or less confident now that you guys are doing so well? More confident. Okay, very good. With that being said, thank you so much for doing the lectures with us. Okay, please let us know if you guys have any questions. Send us an email. We will answer them for you. If you guys have any students who wants to join the lectures, let them know this is the best time to join the lectures, because we will be starting with a very great topic, that is genetics and biochemistry, from next week, along with the use of physio side by side. And at the same time, if you guys like our lectures, please leave us a review on our page and give us a feedback, so we know if there's anything we need to do to improve ourselves. Okay. And that, like, if you have a friend who's struggling, please ask him or her to send us an email. We'll help them out. Okay. Are you still offering 1-day free trial? Yes, we are still offering 1-day free trial. Okay. Okay. Sure. Yes. Okay. If it's a reference, then yes, then we will give a 1-day free trial. If anyone is being referred, then yes. If it's a new student, then no. Okay. If it's a referred friend, then obviously we'll give them a 1-day free trial. No problem. Okay. So that's that. And so with that being said, thank you so much. I would like to take my leave right now. And please don't forget the transactions before Monday to receive the Zoom URLs, because we have been pretty strict with all the students this week for some reason, because what we said, that we have connected PayPal to our emails. So the students who complete the transactions will get the links, and that's how we operate right now. So please, if you do not feel like there's a possibility you can complete the transactions, if you do not let us know via email that you need extension, that unfortunately we will believe that you are no longer interested, and we will stop bothering you with the lecture URLs. Okay, so thank you so much once again. Hope you guys have a great weekend. Do not forget there's a possibility that you guys will receive an assessment exam this Saturday. Okay, this will not be a big assessment exam, or it might be a small one on reproductive system. And that's that. Okay, if everything goes well, then I'll see you guys on Monday at 9 a.m. Okay, you guys have a great day and a great weekend. Thank you so much for being with us. I'll take my leave right now. Have a great day. Bye-bye.